So good morning, good afternoon, good evening, everyone. So I think we have to start this meeting so that we have to save time, not accumulate too much delay since the very beginning. Otherwise, it will be a nightmare. We will finish, I think, tomorrow morning. So thank you. I cannot be so thankful to all of you for gathering here for a meeting, which is a meeting conceived to reach a consensus on a very special topic of clinical complete response in bladder cancer. We have the pleasure to have so many of you, so many key opinion leaders from multiple specialties. I cannot be more proud for having you all sitting down virtually or in presence here for this topic. We will have the pleasure to hear from the agencies also. We have friends from FDA and EMA. So let's keep the discussion lively. Please feel free to make comment. The meeting is intended to be an open discussion primarily. But at the same time, we will keep a close eye to the timing for sure. First of all, a few housekeeping notes. Please, for those of you who are virtually connecting, please keep your camera on so that we can see you. We will have the pleasure to see you. All the slides that we present and the people we present today have been collected in a repository that will be made available to all of you. So all of you will have access to the possibility to download the slides for the entire meeting. And the meeting will be conceived to also to generate a manuscript for this topic. So you will hear from us and you will have updates on the developments of the manuscript later on. So I'm not alone. I'm in a very, very good shape here because the co-chairs of this meeting are pretty well-known guys. Ashish Kamath, Phil Spiess and McGalsky, who is joined virtually. So a few words with all of them, and then we will start with the session. So let's start from Ashish.
So I want to echo what Andrea said and welcome all of you all to this very, very important meeting. Just to share a little bit of Andrea's leadership and vision, this is a conversation we had at the IBCG meeting a few years ago when we were talking about what we do with the guidelines and how we've interacted with Elaine, for example, who's on the FDA right now, and the folks. And Andrea was like, there's a very important topic that we need to address, which is CCR, because of all the trials and the requests from the patients. And from that little conversation to today, in a short time for this to be organized, for all of you to be able to take your time and put in your effort and expertise, on behalf of Andrea, Phil, and everybody else here, and Matt. Hi, Matt, just seeing you on the screen. I really want to welcome all of you to this and thank you for taking the time to join us.
So first of all, thanks everybody for being here. It's an absolute privilege on behalf of our Global Society of Rare GU Tumors to be part of this conversation. Andrea, congratulations. As we all know, when Andrea has a concept, he takes it all the way, and just seeing all the thought leaders that are in this room that are going to be engaging in this conversation. I know we're going to achieve a lot. I know we're going to have some really thoughtful conversations, but it's an absolute privilege, again, to be here. Thank you for taking the time, and looking forward to hearing from you, getting your thoughts, and for us to, at the end of the day, be able to find consensus as we all agree with. So thanks, and looking forward to speaking with all of you today.
Thank you, Phil. Matt, please. We cannot hear you. Is there any technical issue? Let me check.
Virtually, but maybe
yeah,
not.
exactly.
Yes.
Now we hear you.
Okay, so I'll keep it brief. This is a complicated topic. The stakes are really high, and so I think it's really important that we get this right. And so I thank everyone for being here.
So thank you. Without spending too few more words, I think that it's the case to start with the first lecture. I will. It's my lecture. I will be very brief in summarizing the data that you much better than myself already know regarding the neoadjuvant studies. So if I may have my slides. So just to recapitulate what data currently stand. Is it possible to? Perfect. So the fresh updates from the neoadjuvant studies. Let's see if okay, these are my conflicts. So basically, this is the model, the clinical stage around which we are dealing today. The clinical stage T2, T4, N0, N1, M0, MIBC, pure predominant urothelial cancer histologies. This is a pretty well shared model for disease management, and that this shared across the studies. This is a summary of the studies with immune checkpoint inhibitors alone or in combination, immune combination, neoadjuvantly. The latest data are on the far right inside with the Optimum study with the retifanlimab monotherapy. The PT0 and 0 rates are pretty much consistent with very few exceptions across the studies and ranges between 35 and 40%. So overall, we do have a signal for activity. Maybe not sufficiently good to envision a future for sparing the bladder, at least to unselected patients based on the numbers, but it is part of the discussion that will follow the presentation. And these are, as you well know, the combination therapy data. The latest data came from a bit different chemotherapy backbone combination with a new combo with putting taxane in combination with immune therapy. Again, here a lot of controversy as regards the intermediate endpoint of pathological complete response, as we do not see any huge disconnection as compared to the standard of care chemotherapy or the immune checkpoint inhibitor use, as you have seen in the previous slide. But we do have trials, as you know, in the perioperative space. They are targeting the neoadjuvant and the adjuvant period with the maintenance therapy post-cystectomy. And as you well know, that the first study to provide the data readout was the Niagara study. It is a huge study, a huge effort of so many patients randomized to receive durva gem-cis followed by cystectomy and adjuvant durvalumab versus standard of care cisplatin gemcitabine combination followed by cystectomy and bioobservation. The PCR was the co-primary endpoint together with event-free survival. Overall survival was a secondary endpoint. This study, as you know, provided an improvement in DFS and OS in the experimental arm with durvalumab combination. A pretty advanced tumor stage, as more than 50%, 60% of the patient presented with more than clinical T2 stage. 5% of the patient presented with an N1 disease, and the combination therapy just received a few days ago a priority review by the FDA. But with regards to the endpoint here in Niagara, or the pathological complete response, it's a tricky situation because you see on the left-hand side and the right-hand side two different analyses. The left-hand side is the primary analysis, the right-hand side was the updated analysis with additional more numbers. But overall, I think that the message is pretty much controversial as regards the pathological response rate, because on the red box you see the latest data, the most modern data from the chemotherapy, for standard chemotherapy trials, the MVAC chemotherapy in the Vesper study or the gem-cis chemotherapy from the Coxen study. So not differentiating too much as compared to the Niagara studies with regards to this endpoint. And 6% of the patients in Niagara did not receive radical cystectomy for a reason other than disease progression. We do have, what is missing, at least in Niagara, is the immunotherapy part, as monotherapy or combination therapy. And this is being investigated, as you know, in cisplatin ineligible population, and the data readout from this study is still pending. But there are data currently available from a bit different strategy. So one of the focus of my talk would be the struggle between intravesical and systemic therapy in muscle-invasive disease. This is a relatively new concept. The Sunrise 4 study, part of the Sunrise platform testing TAR-200 in early stage bladder cancer, tested TAR-200 in combination with cetralimab, an anti-PD-1 antibody, with another cohort, parallel cohort of cetralimab monotherapy as a period of neoadjuvant therapy prior to radical cystectomy, having a PT0, the pathological complete response rate as the endpoint, and the data, the summary of the data with regards to the primary endpoint of pathological complete response or pathological major response, meaning downstaging to non-muscle invasive disease, are summarized here. Have been presented at ESMO a few months ago. 42% in the PCR rate in the unselected population with the combination of TAR-200 and cetralimab. There seemed to be an enrichment in patients with minimal infiltrating disease, as you can see on the left-hand side, with clinical T2 stage, with the PCR almost reaching the 50%. And there was clearly on the right an association with the exposition of the TAR-200 with regards to the efficacy on the bladder. A similar concept has been pursued in the core 002 trial, testing intravesical adenoviral therapy with cretostimogene in combination with nivolumab. This is the Roger Lee paper published in Nature Medicine. The data are pretty much similar, with 40% pathological complete response rate with the combination therapy. Preliminary relapse-free survival looks good. There is some toxicity, but not too much. So another strategy putting the eye on the possible combination of intravesical and systemic therapy. So looking back on the bit earlier disease stage, like a non-muscle invasive disease, BCG, CIS, BCG unresponsive disease, you see here the data as it currently stands with regards to the various study, with regards to the clinical complete response. The orange boxes are the 12-month CR rate, the blue boxes are the 6-month CR rate from various studies, and you see above the quality, the nature of the study with single agent intravesical therapy or the combination of intravesical and systemic therapy. We do not see any huge disconnection. So here, and maybe also in the muscle invasive disease, the contribution of the systemic therapy addition with immune therapy is still controversial, waiting for the longer term data. And there is the unique study, an academic study ongoing today in Europe, running in Italy, Spain, and France, testing for the first time targeted therapy neoadjuvantly with erdafitinib alone or in combination with cetralimab prior to radical cystectomy, and the study is currently recruiting patients. So overall, my take for the neoadjuvant study is that, okay, Niagara is pretty well positioned for sure, together with those dense and VAC, when we deal with a success area of 2-year overall survival rate of higher than 80%. What about the pathological complete response, the interim endpoint, when we aim to spare the bladder or to identify a regimen that could be pretty well positioned to make the next step, the next move to the design of bladder sparing trials? We are a bit below what I consider personally a 50% area of success for a PT0 rate in order to consider a certain regimen that's suitable for a bladder sparing approach. But for sure, it's a matter of today's discussion. We do have ADC with some issue related to toxicity, but the readout of data from EV monotherapy, SG monotherapy, and disitamab vedotin and topalimab combination therapy have been provided, recapitulating basically the data that we have already seen with immune therapy or immune chemotherapy combination therapy. So we have to wait for the randomized studies. And this is the final slide, just presenting a typical case around which we are discussing today. The good point is that I'm not dealing with, I've not started my thinking on science, but thinking about my daily practice, you know. This is my current situation of a patient, of a young woman achieving a clinically deep response to standard of care chemotherapy, and then questioning the need to undergo radical cystectomy at that time. So not baseline, not a priori, but based on the depth of response she achieved with, in this case, with the standard of care chemotherapy. So around this type of patient, we will play our game today in discussing what we could consider as intermediate endpoints and maybe the shape of the next clinical trial design. So I will close here. There is no discussion now. We'll discuss later on. I will pause myself and leave the presentation to Matt, who will update us with the concept of clinical complete response based on this on his huge work he has done with the recent trials. Thank you, and please, Matt, the floor is yours.
Thank you. And I'm sharing my screen, correct?
Yeah, you have to. All of you, you have to share your screen. Thanks.
And it looks like someone needs to stop sharing for me to share.
Please, team, are you able to stop?
Okay. Before I close this window, can everyone see my slides?
Not yet. Okay. Now it's okay.
And you can hear me?
Yeah.
Okay, perfect. Okay, so thanks again, everyone. So I'm going to talk a little bit about how we might contextualize clinical response to inform individualized treatment approaches. And I'm going to start with this slide because a lot of what I have to say today is about how we define things and how we need to define things concisely. And just because we call things by the same name doesn't make them the same thing. So this is our standard approach to treatment of muscle-invasive bladder cancer. A patient's diagnosed, ideally, they meet with multiple providers in a multidisciplinary fashion, arrive at a shared medical decision, and then that treatment approach is pursued, and then we wait and determine outcomes. An alternative approach, which I'm going to refer to as a risk-adapted individualized approach, is after a diagnosis, if systemic therapy is deemed appropriate, then systemic therapy is given. Information is collected about how an individual patient might have responded to that treatment. And then based on that, a decision is made about the next step in treatment. And here, of course, one of the treatment decisions to be made is whether or not the bladder can remain intact or not. And for the purposes of this talk, for a clinical complete response achieved in this setting, a variety of different interventions could be considered. Intravesical treatments, like we've heard about from Andrea, radiation. There's a really nice trial being designed right now to explore radiation in this context, or one can think about no definitive local therapy in that context. So why would we ever think about doing that? Well, one reason is because patients have been telling us they've wanted this for really decades now. And this really dates back to the origins of multi-agent platinum-based chemotherapy in the neoadjuvant setting in bladder cancer. It's a paper from Harry Hurd, Dean Bajorn, and Howard Scher, probably mentors to many of us involved today. And in this paper, after receiving neoadjuvant MVAC, patients underwent a repeat TUR. In patients who had a T0 status based on that TUR, many patients declined pursuing definitive local therapy. And in this experience, you can see that they report the majority of patients who achieved a T0 status had durable disease-free bladder intact survival. And so retrospective studies like this tell us what can be achieved, but they don't necessarily tell us what should be achieved or how it should be achieved, or I would actually say, or how it was achieved, and I'm going to come back to that point later. And so this paper was over 20 years ago, reflecting the experience of patients treated over 30 years ago, and still this approach is not part of our standard treatment paradigm. So why is that? And I would say these 5 considerations are what I consider to be the key barriers to advancing a strategy of TUR plus systemic therapy as definitive treatment for muscle-invasive bladder cancer. And I would say that the first 2 are probably the most important. We just don't have a lot of prospective studies in this area, and we have a lack of uniform and rigorous methods to both measure and define what clinical complete response means, and that's really one of the reasons that we're here today. We also have a limited understanding of the role of delayed cystectomy in patients who achieve a clinical CR and then develop local recurrence. We probably had suboptimal systemic therapeutic regimens historically, and of course, the absence of biomarkers to help refine treatment decision-making. So in the next few slides, I'm just going to lay out a framework for how we might think about this individualized risk-adapted treatment strategy. And I'm going to say some things that are probably quite obvious, and I'm going to say some things that might be considered somewhat controversial as well. I would ask that you keep somewhat of an open mind. We get very entrenched in our ways of doing things, and to think about doing things in another way is oftentimes difficult, so bear with me. I would argue that for most patients, these three boxes here represent the optimal goals of treatment. Patients want to be cured. They would like to have an intact bladder, and they would like to have no chronic side effects. And how each patient values and prioritizes each of these boxes is probably a little bit different. We talk a lot about personalized medicine. Well, achieving the optimal balance of these three parameters in an individual patient is personalized medicine. But the way that we develop therapeutic regimens today, really, there's a tension between what we define as the best treatment for a disease and the best treatment for individual patients with that disease. And I would say that we've been really focused over the past decade and a half on pre-treatment predictive biomarkers, and those have been somewhat elusive in terms of allowing us to refine our treatment strategies, but we leave a lot of information on the table about what's happening in a patient in the context of treatment. And I would argue that interpreting the present is probably a bit easier than predicting the future. And so we need to think about how we use that information. I had mentioned that these retrospective studies tell us maybe what can be achieved, but not how it was achieved. And for that, we turn to the neoadjuvant experience prior to cystectomy. We know that a subset of patients treated with neoadjuvant chemotherapy followed by cystectomy will achieve a pathological complete response. And we know those patients will have better outcomes. It's a pretty good individual level endpoint. Maybe not a trial level surrogate yet, but it's a pretty good individual level surrogate. I think we have pretty good data for that. And so that really begs the question, who are these patients on this path CR curve? And I would argue that this really encompasses three groups of patients. One group are patients who have micrometastatic disease for whom the systemic therapy eradicates the micrometastatic disease and the primary tumor. And for those patients, TUR plus systemic therapy would be the optimal strategy. They need systemic therapy, but anything else would be over treatment. So that would be the ideal scenario. There's probably also patients in that curve who have a primary tumor, no micrometastatic disease, and the systemic therapy is required to eradicate the primary tumor. And then there are patients who have a primary tumor that was eradicated with the TUR alone and probably don't need the systemic therapy. Of course, as mentioned, our challenge is identifying these different scenarios a priori, because if we could do that, we could refine our individualized treatment strategies even better. We're not that good at that, but we're a little bit better at measuring this. And so you might say, well, that's all great, but I can show you a bunch of studies that show that path CR and clinical CR don't really line up that well. And I would say all of those studies to me are answering or providing the right answer to the wrong question. And I'm being a bit facetious because obviously these parameters need to line up a little bit, because I just told you that path CR might explain why some patients can have durable disease-free, bladder-free, bladder intact survival after TUR plus systemic therapy. But I don't think they have to line up perfectly. I don't think they have to line up quite as much as we think they do, because at the end of the day, path CR is not an important endpoint either. It doesn't measure how patients feel, function, or survive. It's another intermediate endpoint. So we're trading one intermediate for another. And what's more important is whether or not clinical CR predicts some long-term outcome that's important to patients that allows us to make treatment decisions in a refined and individualized way. And of course, part of the missing piece here is that we really don't know the biology and treated history of local recurrence after clinical CR that well. We don't have that many studies that have explored that. Salvage local therapy has played a key role in organ preservation in virtually every other solid tumor. And I would argue that if, and I underline if, cancer control is not compromised, then the risk-adapted individualized approach is still favorable to an upfront cystectomy for all approach in terms of achieving both the goals of cancer control and bladder sparing. There's a complex calculus here, of course, between a one-size-fits-all approach and a risk-adapted approach, because with the risk-adapted approach, there's a variety of different scenarios that can play out, and each of those affect this balance of bladder sparing and cure differently. And I would say the outcomes are quite complicated, and there are competing risks here. And so this is really best summarized as a health state transitions model. Patients who undergo cystectomy can't be at risk for an in-bladder recurrence. Patients who don't undergo cystectomy could be at risk for a variety of different disease state transitions. And there are competing risks, such as a patient who develops metastatic disease. Obviously, cystectomy is not appropriate for that patient. So we talk about salvage cystectomy rates with one treatment versus another. That's sort of meaningless, because if a patient develops metastatic disease, then whether or not they have a quote unquote salvage cystectomy or not would not be an appropriate endpoint. So we need to think about the endpoints carefully. And I would argue that clinical CR is not the endpoint, but it's actually a biomarker. It's the starting place. And if we want to think about clinical CR as a biomarker, we need to apply biomarker principles, and that includes how we think about maximizing analytical validity. And one of the best ways to achieve this is to define this, is to measure it uniformly and define it stringently and consistently. And if we don't do that, then when we talk about clinical CR, it's as useless as talking about PD-L1 positive, right? What assay, what cut point, what cell population? Retrospective studies and anecdotes are insufficient here. Consensus is important. It's critically important. That's why we're all here today. But at the end of the day, biomarkers are not defined by consensus. They're defined by data. And so any definitions that are proposed, we need to think about how we support that with prospective assessments, ultimately to establish clinical validity and then clinical utility. So what tools do we have available to assess clinical response? Those in the purple are what have been used traditionally. We have some emerging technologies that we're going to hear about today. But of course, all of these things in the purple box can be done in very different ways. So imaging, what imaging? If we do cystoscopy, do we just look? Do we do a biopsy? Do we do mapping biopsies? And all of those details matter. They're critically important. So if we look at some of the contemporary studies that have prospectively assessed an individualized risk-adapted approach based on clinical response assessment, you could see that the assessments that have been used have been really across the board a bit, and the definitions of clinical CR are not consistent. In the last just couple of slides, I'll show you that the approach that we've taken is to recommend mapping biopsies, not just cystoscopy, not just biopsy, but mapping biopsies of the bladder, because if the bladder potentially is going to be left intact, we want to know as much as possible. MRI rather than CT when possible. We'll hear more about that today. And of course, urine cytology could be a tool here as well. And if all of those assessments reveal no evidence of cancer, then that's a clinical complete response. Why mapping biopsies? Well, a repeat TURBT is likely insufficient. So here's one patient example on our bladder sparing trials who had baseline tumor muscle invasive disease. You could see on the baseline TUR. On the restaging TUR, you could see that there was a high-grade TA lesion at the site of the original muscle invasive disease, but multiple other areas of involvement, including high-grade T1 disease at the prostatic urethra. So we want to know as much as possible about what's going on in the bladder. The last point I'll make is that pathology and imaging are complementary tools here. They're not redundant, they're complementary. And if you look at many of the studies that have compared clinical CR and path CR, it's actually just based on the TUR. The imaging is not included. And we need to think about integrating both of these into our definitions. So here's another example. A patient underwent the restaging biopsy after systemic therapy, no evidence of cancer. There was actually nothing on cystoscopy. And there's this lesion on MRI, which has subsequently been proven to be a residual disease. So we need to consider how we integrate both. Clinical CR needs to be measured rigorously and uniformly. It needs to be defined. Clinical complete response needs to be defined explicitly and consistently. And this is not just an endpoint, it's a biomarker, and we need to approach it as such. Thanks for your attention.
Thank you so much, Matt. I mean, as always, you are able to take a complex topic and distill it into bite-sized chunks for all of us to understand, so thank you. A little housekeeping item before we move on to Sarah Sutka. If any of you need to contact either myself or Phil or Andrea, feel free to do so by text or chat. The online chat is being monitored, but it may not be monitored real time. So if you're having trouble with something, just text one of us and we'll address it. To introduce my next speaker, I want to say apologies for waking you up really early, Sarah. Our next speaker is Dr. Sarah Sutka, who's joining us from Seattle, and she's going to present to us the urologist perspective, when, how, and why we avoid radical cystectomy. And I think this is really important because there's one statistic that really amazed me when I heard this, and I heard this at a patient-centric care conference where it was brought to our attention that for every 1 hour that a muscle-invasive bladder cancer patient spends with our medical oncology colleagues, they spend 11 hours with the urologist. So it's really important that the urologist, not just obviously those in the room and on the call, because all of us believe in it, but the community of urologists buys into this concept. So with that, Sarah, no pressure, but take it away.
Thank you so much. Can I just also confirm you can hear me and see my slides?
We can hear you, we can't see you. Can we spotlight Dr. Sutka as the presenter, please? There you go.
Okay to go ahead?
Yes.
Well, okay, thank you. Thank you, Ashish. Thank you, Andrea. Thank you, Phil. Thank you all so much. I'm really grateful to be a part of this. And thank you, Matt, for that incredible presentation. So my task is to really just bring in the urologist perspective here. And I think that it goes without saying that I was sitting in clinic yesterday and saw over 12 patients at various stages of their bladder cancer journey, and the relationships that we as urologists have with these patients, often diagnosing them, bringing them through a lot of times a period of intense treatment in the non-muscle invasive space, and in those situations where we see progression, we develop these intense relationships with patients where we learn their priorities and have to help them work their way through some very complex decision making should that disease progress to the muscle invasive state. Now, it goes without saying that in 2024, the paradigm that you just heard from Matt and which you see before you is the standard of care in terms of how we handle muscle invasive bladder cancer. And most patients will track along this top curve, which is really moving towards neoadjuvant chemotherapy with the objective of both downstaging the disease, hopefully achieving that pathologic complete response, and then consolidating any micrometastatic disease before progressing to radical cystectomy with the goal of consolidation. And then in those patients who persist in terms of having extensive disease, we consider adjuvant immunotherapy. Of course, there's also the trimodality therapy or chemoradiation approach, which has extensive utility in highly and carefully selected patients. And as you also just heard, I would say that the paradigm is shifting as we start to consider more the role of perioperative systemic chemoimmunotherapy with expanded options in terms of systemic therapies. And I think that the way that we consider surgery in this context is going to shift quite a bit. I'm going to just highlight that as something that we're going to need to think about, because a lot of the data that I'm going to present does not obviously incorporate that sort of a paradigm. But the big question here is why do we want to omit RC? How and when should we consider doing so? And I will limit my remarks here to omitting radical cystectomy with the goal of keeping bladder intact and bladder untreated. Local consolidative therapy with chemo and radiation is obviously an important consideration and will be utilized as a bladder sparing approach in select patients. And there's certainly some analogous points for how can we actually keep the bladder untreated to avoid the side effects of therapy of doing so. This is probably the most important slide in my talk, and I'll take a few minutes just to walk through it. At the end of the day, when a patient presents with muscle invasive bladder cancer, what do they care about? We know from surveys of patients and all of our interactions with patients that cure is obviously one of the priorities. but it is one of the priorities. It is not the only priority. And so the other things we have to consider when we're talking to patients about considering therapy for their muscle-invasive bladder cancer are all of these other patient-specific factors. Patients care about the preservation of their bladder and specifically the maintenance of normal functional voiding. Functional voiding, of course, incorporates, I would say, healthy voiding. Patients who are not, for example, who do not have a crippled bladder because of the number of therapeutics that they've been exposed to, such that they are voiding repeatedly around the clock and up all night and sacrificing healthy sleep and really quality of life due to dysfunctional voiding. The impact of the urinary diversion is probably one of the most important aspects of the radical cystectomy. I would say that the radical cystectomy is an implicitly complicated operation, not only because it's an extirpative procedure where the bladder and men and women, the reproductive organs are removed, but because of the reconstruction and the long-term sequela of exposing intestine to urine, and also the implications for subsequent bone healing. We know that there's an increased risk of, for example, fragility fractures among patients who have undergone radical cystectomy related to the acidosis. We know the impact on renal function, and we know the long-term surgical complications in terms of hernias, need for reconstruction, ureteroenteric and anastomotic strictures, and so on and so forth. Obviously, this operation impacts sexual function in a major way. And then all of this comes together to impact health-related quality of life across all domains, the physical, the mental, and the social. There are personal attributes in how patients perceive themselves with respect to the cosmetic appearances and how having these reconstructions will forevermore change the way that they live their lives. I think there's certainly impacts here with respect to priorities around confidence in the treatment and trust in the clinician, and obviously, clearly avoidance of toxicity in the short term and the long term, because these are once we do an operation like this, there are lifelong implications. So the case for cystectomy, why is radical cystectomy central to our management of muscle-invasive bladder cancer? Well, there's kind of three reasons why we consolidate the bladder, even when we see a pathologic complete response or no evidence of disease, at least based on conventional imaging in the current paradigm. Well, first of all, we're to prevent future recurrences. We are, sorry, I may hear some additional speaking. I'm hoping you can hear me as well. We are attempting to ensure that we remove any recognized or unrecognized treatment refractory residual disease. These are cancer cells that have been exposed and persisted despite standard of care systemic therapy. And the idea is to both prevent them from persisting and progressing within the bladder, but also outside of the bladder, as these may function as seeds for subsequent metastases, which may be treatment refractory. And then obviously here, we're also talking about risk stratification in order to determine whether we need to intensify therapy and expose patients, for example, to subsequent adjuvant immunotherapy. And so I would say that there are concerns, though, with radical cystectomy, both in terms of considering the risk of undertreatment and overtreatment, and I'll highlight a few of those concerns. So why do we want to omit radical cystectomy? Well, I just spent a lot of time telling you about all the reasons why patients seek to avoid the morbidity and mortality of this operation and the challenges in recovery and the impact on independence as well as long-term health-related quality of life. But we also want to omit radical cystectomy when that operation is not going to benefit our patients. So there may, as we all know, and I think we're all sitting in this room right now because we're worried that RC is vastly overtreating some patients. And in patients who achieve pathologic complete response, that surrogate marker would suggest that, based on data that we've seen from SWOG studies and many others, that we're overtreating those patients who may not need to have their bladder consolidated. And so this may present an opportunity to de-intensify therapy and improve quality of life in the long term. But RC may also be under treatment if there is micrometastatic disease that persists after neoadjuvant chemotherapy. And those are the patients who are destined to progress distantly, and in which case, consolidating the bladder may actually just be subjecting those patients to unnecessary local toxicity. And therefore, we may be able to avoid the long-term sequelae of radical cystectomy in these patients who really do ultimately require systemic therapy. And the toxicity of the surgery, in some cases, can preclude the receipt of that systemic therapy, thereby negatively impacting the length of their life. So the question is, who can we avoid radical cystectomy in to de-intensify therapy, and who can we avoid it in because it's actually not necessary and it's taking them down the wrong treatment path? So we really need to accurately determine which patients need local consolidation of the bladder. We know from unselected patient populations, this is a National Cancer Database series, if we omit radical cystectomy after TUR and neoadjuvant chemotherapy, the outcomes are abysmal, with 2-year survival rates of 50% or less and 5-year overall survival rates of less than a third. Of course, this is retrospective, highly confounded data, but obviously this is not the kind of outcomes that we would be willing to consider or accept. There is some retrospective data that would suggest that if we are careful in whom we select for active surveillance based on this surrogate biomarker, and I love that framing that we just heard from Dr. Galsky of that as a potential selection criteria, we may be able to identify patients who successfully can have their bladder spared and avoid surgical consolidation. So in this retrospective series, it was a multi-center study of 148 patients. In patients who had no tumor on subsequent TURBT, negative cytology, and no disease on conventional imaging, we see that the disease-specific survival at 5 years is 90%, and the cystectomy-free survival is 76%. And that prompted the authors to suggest that this could be a reasonable strategy to continue to pursue. Of course, the other point here is, are we missing the window of cure by not taking these patients to radical cystectomy? And this is just the analysis of this retrospective data. Among the 15 patients of that 148 who went on to die of bladder cancer, 11 of 15 died of local recurrence. These are patients that surgical consolidation would likely have prevented that death. So there's a 7% additive mortality risk with an active surveillance approach in this patient population. But 4 of those patients went on to progress systemically. And those are the patients for whom radical cystectomy was probably under treatment and not appropriate treatment. But we obviously are struggling to identify those patients with conventional imaging methods. So we really do need to identify those patients who will recur locally prior to recurrence in order to understand who really does need radical cystectomy, and therefore the contrary, in whom we can consider avoiding that operation. So the critical assumption here is that clinical T0 is pathologic T0. And here, of course, we know that pathologic complete responses after to date, conventional systemic therapy given preoperatively approaches 40% in some series, but of course this is identified at radical cystectomy, and conventional staging, as we know, is unfortunately not quite meeting the mark. It's accurate in somewhere between 1/3 and 2/3 of patients, but we miss muscle invasive disease with conventional imaging in up to 40% and miss node positive disease in up to 15%, with a historical correlation between clinical response and pathologic response when we use this conventional staging approach being relatively poor. So we need to be able to prove that we're talking about the right things, and that clinical complete response really does reflect that pathologic complete response. And that's a lot of what we're going to talk about today. I'll just highlight a few of the examples of papers that have looked at what the state of the literature to date would suggest about this critical assumption. So we're going to talk about endoscopic evaluation, imaging, and biomarkers. And then I would say that a lot of the retrospective series that have assessed whether or not this strategy could be considered as a rational paradigm have suggested, from a patient-specific factor, if we're thinking about sparing the bladder, we want to include patients who do not have CIS, who lack variant histology, and obviously who don't have hydronephrosis, which is a proxy for more advanced disease. The C trial was run out of Fox Chase. This was the systemic endoscopic evaluation after initial systemic therapy, published in Journal of Urology just recently. And in this patient population, in which it was a window of opportunity trial where patients underwent a biopsy of visible tumor, the biopsy of the prior tumor site, and random biopsies at the time of radical cystectomy to understand the potential benefit of this systemic endoscopic evaluation. And basically, the punchline is that this study was stopped for futility because the patients who on the endoscopic evaluation were characterized as being T0 were about as likely to harbor no disease as they were to have disease at the time of cystectomy. So it did not meet its pre-specified endpoint in terms of demonstrating the accuracy of this approach. MRI is emerging as a really valuable part of our staging armamentarium in bladder cancer with the VIRAD system, which establishes and evaluates patients for invasive disease. And we know that it's actually quite good at characterizing invasive disease. The accuracy of predicting clinical stage with MRI is somewhere between about 40 and about 85%. And but it's again about 1/3 to 2/3 accurate in predicting clinical complete response. And you can see here the data from the PURE-01 analysis. The point here, though, is that VIRADS is probably not ready for prime time to predict clinical complete response. And if we use cutoffs of less than 2 or less than 3, this study would suggest that, yes, you can certainly identify in a statistically significant way those patients with clinical complete response, but the accuracy is still about as good as a flip of a coin, or maybe 2/3. That's really not quite meeting our benchmark. And of course, there's a great deal of interest in whether or not we can utilize radiomics to advance our understanding of better characterizing pathologic staging using MRI. But I guess what I would leave you with here in a very simplified overview of the radiomics literature for predicting complete response at this time is that most of the models are still lacking in robustness and reproducibility, and certainly the vast majority of them have not yet been externally validated, which is going to be absolutely critical before we consider implementing them in our clinical care pathways. And then, of course, where we're moving is integration of molecular biomarkers. And you're going to hear a number of different studies that have started to adopt this paradigm. And just highlighting here, for example, ctDNA for the detection of minimal residual disease. Data to date would suggest that this does do a better job of predicting recurrence-free survival when compared to pathologic complete response. And so that's very promising. Now we have to learn a lot more about how we utilize this biomarker when we obtain it, and also how we use it to assess sort of a response to disease. But the final piece of the equation here is something that I spend a lot of time thinking about, which is the patient perspective. And we're going to hear from Rick Bangs a little bit more about this, and I would just encourage you to listen so carefully to what he says, because shared decision-making around radical cystectomy omission is absolutely critical. And I would argue that patient priorities here need to take front and center stage as we start to integrate omission of radical cystectomy into a risk-adapted paradigm. We need to hear from patients their level of tolerance of risk, and ultimately, among all those priorities that I talked about at the very beginning, which they weight most heavily, because that's going to ultimately drive whether they are willing to accept the risk of potentially harboring some persistent disease within the bladder that we haven't been able to identify, with the objective of preserving their native bladder, or whether that, for example, is a no-go in that situation. And I think that ultimately that's where shared decision-making becomes just so critically important. So in conclusion, the critical needs from the surgeon perspective prior to acceptance of omitting radical cystectomy after systemic therapy, and I would call it in this case now, we're moving away from the neoadjuvant concept to just an initial systemic therapy practice. We need to refine and validate this biomarker defining clinical complete response with contemporary initial systemic therapies. We need to understand which patient factors need to drive our decision-making around response. We need to understand better how to use the conventional imaging modalities we have and integrate radiomics. Certainly, the rule for pathologic and endoscopic evaluation is critical, and I think the mapping biopsies is going to be a part of that, obviously, to rule out coexistence of pathologic risk factors such as carcinoma in situ, and then the role of biomarkers remains to be defined, and I think is going to be critical here. Importantly, we need to identify those patients who are going to recur locally despite response, and those are the patients where we need to actually understand what salvage treatment is going to look like, the oncologic benefit of that sort of a strategy in the disease process of muscle-invasive bladder cancer. We need to identify those patients with micrometastatic disease in the setting of clinical complete response, and those patients certainly do not warrant bladder consolidation because that is not the treatment that they need. They need more intensive systemic therapy. And then on an individual level, we need to ensure that every single study that we do to validate this pathway includes the patient perspective and carefully tracks quality of life data after initial therapy with bladder intact in order to help inform our shared decision-making conversation with patients to ensure that patients are making appropriately informed decisions. And so ultimately, I will leave you with this. The question is whether or not we can change our paradigm with the goal of preserving the native bladder and all of the potential benefits that that has for patients' quality of life. But we need to prove that clinical complete response can be identified and that omitting cystectomy in those patients does still preserve the window of cure for patients in whom that is a high priority. And with that, I will thank you so much for your attention and look forward to the discussion.
Sarah, that was absolutely exceptional as usual. You gave a very thoughtful, very balanced perspective that I think, obviously we struggle with when we have these conversations related to cystectomy. I'm definitely not the only one in the room, but I know just 2 weeks ago I did a cystectomy and, lo and behold, luckily that patient did well, but a T0, N0, that is not a success for any of us, right? It's clearly, that's over-treatment is the way we look at it. And, we always apply the retroscope, go back to the imaging, go back to this, cystoscopic findings. And like you said, often it is a balanced approach with the patient, but sometimes even regardless of that, we feel terrible when we've over-treated those patients, and we clearly ask ourselves, we should do and we need to do better for those patients. So thanks for giving that great perspective. I think we're going to move on, and I think Larry Schwartz is going to give us the next presentation, and I know afterwards we'll have a conversation, discussion among all of us and our speakers online. But Larry's going to give us the perspective related to the radiologist's view and how we can improve the accuracy of cross-sectional imaging. Obviously, we know some of the challenges, particularly when patients have received treatment, and understanding what is potentially treatment effect versus what is residual disease. So Larry, thanks for participating. And we're looking forward to hearing from you related to your thoughts and your perspectives on how we can improve, ultimately, how we use treatment response as a surrogate.
Thank you. And I want to make sure you could see my slides and hear me.
Yes.
Okay, great. Okay, so from the radiologist's perspective, as stated, how do we improve the accuracy of cross-sectional imaging? And while I'm a radiologist presenting this data, it really is driven by our team and all of you. And I'd like to acknowledge Jonathan and Hikmet, who are online, who really helped drive a lot of this research, certainly from the clinical perspective. So in terms of improving cross-sectional imaging, I really want to be succinct and list what I believe that we could do. First, obviously, to increase the resolution, increase the signal to noise of image acquisition, and as we've already heard from 2 of the speakers, utilize a multi-parametric MRI and increasingly actually CT as well. Now, this is really in the domain of the radiologist and of the medical physicists who work on image acquisition. So I'm really not going to spend much more time with this, other than to say that there are, especially with AI, truly techniques where we could double, triple our resolution, improve our signal to noise, actually by decreasing the noise and predicting where the noise will be in an image, by controlling motion, patient motion, physiologic motion within the bladder, within the surrounding bowel, to really improve exquisitely image acquisition. Probably many of you are aware or even have heard from patients that MRI, for instance, is taking a shorter period of time. We've, over the past few years, decreased our MR acquisition times from 1 hour to 45 minutes, now to 30 minutes, potentially even 20 minutes. And in that time, using these multiple parameters, actually have been able to acquire a greater number of sequences that provide increased information for the patient and for you. I think what I'd like to focus on is, for instance, accuracy of tumor segmentation. It's clear that bladder is one tumor where unidimensional measurements really don't play as great a role as we really need for accurate assessment. So we do need whole tumor burden measurement or volumetric assessment of tumor burden. Also, as many of you know and have been involved in multiple of these studies, the precision or the accuracy of many of these measurements is highly variable, depending upon the radiologist and depending upon the technique that's utilized. I believe we could do much better, again, with automated segmentation and clearly with 3D segmentation of these lesions. We've already heard about the concept of window of opportunity studies, and this is absolutely critical. I'll begin with this, I'll end with this as well, that these patient populations, these data sets that are being collected are invaluable. And it's my belief, I think all of our beliefs, that we should really utilize this data to the maximum. So to obtain baseline studies, and as Matt alluded to, we could do certain prognostication in the baseline, but certainly early post-therapy as well. Combined with other biomarkers and correlate with, as we've heard, pathologic CR, but also recurrence-free survival and overall survival. And then finally, and earlier than we've been doing, incorporate imaging into response or risk-adaptive trial designs. I just did a quick screen capture from Matt's talk where he listed 5, the absence of biomarkers to refine decision-making. We certainly have this, but I would also mention that rather than the absence of biomarkers, we haven't appropriately characterized even the biomarkers that we have, and that's what we need to do. So first, in terms of accuracy of tumor segmentation, it's clear that volumetric assessment, 3 different examples here from our institution that Hikmet and Jonathan have worked on as well, that a unidimensional measure cannot actually accurately or adequately, assess, the tumor burden in these cases. So we need full 3D. This is just a single image on 3 different MR sequences, the T2, the diffusion, and the perfusion scans. But again, the role that each of these play with the understanding of a patient's response and with the understanding of pathology is key. But the beginning of that is the automated 3D segmentation to provide better precision, to make sure that at any institution that we're at, with the appropriate image acquisition, which really can be done now, we can acquire images, and then we can acquire quantitative data to accurately assess and begin to understand what we're actually seeing. So the window of opportunity studies, again, I compared to some of the retrospective studies that we do, I'll say that each patient who provides their data in a window of opportunity study with a baseline and an early post-therapy scan is worth literally, maybe I'm exaggerating, maybe I'm not, 100 data sets, in the retrospective manner. Here we see obviously the T1, the T2, the post-contrast or perfusion scan, and then the apparent diffusion coefficient. So what do we do with these? Well, on the T1, we can actually measure, again, here for ease, we measure right now, but we don't have to do this in the future. A unidimensional measure of the tumor here, it's basically the same size, but you could just look at it and see that it's not the same size. The T2 weighted image to evaluate the wall and the extent of disease. The post-contrast image here, we see a difference in tumor viability in a portion of the tumor, and we could see how that actually changes over time. And the apparent diffusion coefficient, looking at restricted molecular movement, over a very, very short period of time to really provide us with adequate and accurate tumor physiology. So in Andrea's study in the post-pembro muscle-invasive bladder cancer, the multiparametric MRI had acceptable inter-observer variability. That's clearly the first step that we have to take and represents the basis for proposing a radiologic CR-NED status. I completely agree with this, and this is exactly the preliminary data that we need to now carry this forward with external data sets so that we can develop bladder-sparing immunotherapy maintenance therapies where we could give more information to you, the clinicians, based on serial imaging. So, we've heard already about radiomics, and this is not because I don't think that we have this data yet. As we've heard, this is a large validation set from one of the keynote Merck trials in immunotherapy and melanoma, where using what I'm calling an enhanced response rate by incorporating radiomics into the concept of a partial response or a change over time, you really see how our CR, PR-like category can really predict very well the very long-term overall survival. Again, this is validation set. This is really the type of data that we need to collect in bladder. Similarly, I'll provide, and this is, I believe, my last slide, I'll provide this concept of tumor growth kinetics. Here in the blue line, we see what frequently happens in patients with a rapid decrease in the size of tumor and then growth over time. And what we want to do in bladder as well, as has already been stated, is really to be able to find some of this information out early on. And even by looking at tumor growth kinetics, even early in the course of therapy, while the tumor is overall decreasing in size, looking at up to 3 data points, we could actually begin to see when there's portions of that tumor on imaging that are actually not responding to the treatment, but are actually beginning to grow. So we and others are using these models for tumor growth by looking early on. When I say early on, baseline up to day 15, 30, 45, after beginning therapy, to understand and to really see, because the rate of growth, and it's this growth component that actually is the component that correlates best with overall survival. So we can ultimately predict long-term benefit potentially much earlier in the course of treatment than we have in the past. And we're referring to this really as an enhanced progression-free survival. The statistical simulation study that I show, though, is in a different tumor type, is in colorectal cancer, where with a small overall survival difference, taking patients from the phase 3 trial, we're able to predict those results much earlier, retrospectively, using the growth kinetic model. Again, this needs to be further validated, but I think we should be collecting this data. So what should we do to improve the accuracy of cross-sectional imaging? First, foremost, to acquire the data accurately. I think that could be done. Centrally collecting the data, correlating the data, and validating the data with what you define as outcomes in clinical trials, and then roll these into clinical practice will be very valuable. I'll again stress that the acquisition of the data, the enrollment of the patients in these clinical trials is really the heaviest lift. So points 2, 3, and 4 are relatively easier to do, and it would be a lost opportunity not to enhance our performance of this so that we can improve outcomes, but also the accuracy of cross-sectional imaging. Thank you.
Thank you so much, Lawrence. I mean, listening to you yesterday and today, it really brings home the fact that this is a true partnership, right? I mean, we have to obviously listen to the reports that you give us, but I think in some ways it's almost like the urologist doing the TURBT should give feedback to the radiologist, and the radiologist could give feedback to the urologist, because otherwise, without that feedback loop, we don't learn and you don't learn, and it's true teamwork, and I commend you for making that so obvious. Next, we're going to move on to the whole reason we're here, right? Why are we here? Why are we talking about CCR? Why are we talking about these endpoints? It's because of the patient. It's what matters to the patient per se. And it's very important for us to recognize that. And we do, but we need to be reminded sometimes. And I really don't need to introduce Rick Bangs, other than just to say that, Rick and I over the years, 20 plus years now, have become close friends. He's someone that's an integral part of the International Bladder Cancer Group. He's an integral part of Beacon, of SWOG, of pretty much most of the guidelines committees. And Rick, other than the podcast, which you and I enjoy doing so much, I also enjoy hearing your perspective on everything that you provide a perspective to. So please share with us your vision on the novel therapeutic journey.
Okay. Can you hear me?
Yes.
Okay, good. And can you see my slides?
Yep.
Okay, great. All right, so I want to thank Andrea and Phil and Ashish and Matt for this opportunity. So I want to just start with kind of the promise and the aspirational side of this, and I'll probably amplify some points that have been made, maybe expand upon some others or add some others. So from an aspirational point of view and a promise point of view, the ability to have no surgery is obviously a big plus. No patient wants to undertake surgery at all, and certainly not a radical cystectomy. We should be striving for broader applicability. We've got lots of patients who cannot have radical cystectomy. So expanding patients that actually receive care can be part of our aspirational goals. And as part of that, we would like to offer at least equivalent quantity of life, maybe even better quantity of life with improved quality of life at the same time. As this has been discussed moments ago, we want to better align who gets what treatments. We want to make sure that patients are not undertreated. We want to make sure they're not overtreated. We want to make sure that the treatment they get is right for their specific tumor. And then last but not least, I do want to point out this aspirational need for access and making sure that whatever the possibility is, that everybody has an opportunity for that possibility. So with that said, with that kind of stating that as kind of the vision, here are some of the challenges that we have. So radical cystectomy is the gold standard. It's the gold standard because it has a relatively high bar. The bar could be higher, but it is a relatively high bar. We still, as we mentioned on the previous slide and has been mentioned today, we still don't know who will and who will not benefit from a specific treatment option. Patients, as you're all, I think, well aware, think of the tumor as being their cancer, and therefore, if you're going to leave the tumor there, that's going to create some anxiety. And then I also want to point out that this whole concept of complete remission, and I heard what Confucius said about the beginning of wisdom is to call things by their proper names. But this is not a proper name that I would have chosen, because I think it's, particularly from a patient point of view, it's very misleading. Complete suggests that there's not going to be anything after it, but we know that that doesn't necessarily happen all the time. Relative to clinical trials, want to make sure that we are properly capturing the long term, and clinical trials are obviously restricted by funding. We obviously want to drive results within a reasonable amount of time. So we just want to make sure that we're capturing the outcomes appropriately from a timing point of view. I don't have to state this, I think everybody's aware, but even surveillance has costs and burdens. And the burdens are not just the financial burdens and the logistical burdens, but there can be side effects there. In the long run, as one of the executives I used to work with used to talk about the juice being worth the squeeze. So at the end of the day, are we getting something that's worth going through all this effort for? There will be some collateral damage in the short and long term based on any given treatment. And that can include the financial and logistical side, but I don't want to focus only on that. There can be medical collateral damage as well. I'm always reminded of a patient that I talked to some years ago who was literally urinating every 30 minutes. At least this is what he told me. And this was true day and night. I don't know how that was possible, but that's what he told me. And yet he was not going to have the radical cystectomy. All right, so, and this is going to come up in the next couple slides too. But patients are going to apply their own set of values, and they're going to want to make their decisions based on their own values, but not every single bladder is going to be worth saving in the long run. And then this issue of access also kind of has an affordability aspect. So, when we have these opportunities to create this vision, is it going to be affordable? Is the surveillance going to be affordable? Is the treatment going to be affordable, both from a time and a cost point of view? And is there going to be, are there going to be any access challenges that, those of us in the US have our own access challenges, but outside the US, we could even think about whether or not a particular treatment or a particular piece of equipment is available at all in a country. So these are things that are going to be challenges. As we get closer to TA T0, and I'm trying to think a little bit ahead, but patients are going to be less willing to take on risk and burden the closer you get to that T0 point. And then, and Sarah, spoke very eloquently on this, but as we're adding choices, shared decision making is going to be so much more critical, and patients should be part of the process and leveraging risks and benefits that they calibrate to their own values and circumstances. And what may be right for me might not be right for somebody else. So last slide here is I just want to give you some key takeaways. We've made tremendous progress. I would never have imagined when I was diagnosed in 2006 that we would be where we are today, which is a good thing, but there's still a fair amount of work to be done. We have a lot of great new agents, and so and we have some also new imaging techniques and opportunities on the pathology side. And so we have these kind of good problems in terms of optimizing sequence and timing and screening and targeting patients. We are trying to expand patients who receive care and making sure that they receive the right care. I think we're doing much better there, but still room to improve. And then this issue of personalization and shared decision-making, those are so critical. And I would encourage us collectively to make sure that we're including the right kind of disciplines and stakeholders in defining shared decision-making and how that whole process works, what the content is, and how it's presented, which I think are both very critical to do. And I think there's lots of opportunity there as we move forward. I think we definitely need to focus on that, and that's not necessarily the people who are on this call. It may be that you need to invite your friends to this that kind of focus on that. And so with that, I'm going to turn it back.
Terrific. Thank you, Rick. Terrific presentation. I guess there are still so many questions from the team. So we will reserve 10 minutes for the discussion prior to the coffee break. So we will be able to share the initial ideas, the initial comments from all of you. Jumping now to the next speaker. When dealing with bladder-saving approach and when considering the standard of care chemoradiation that is there, and in particular, as I didn't want to be killed by a radiation oncologist and I still want to survive, I made the strategic decision to invite the best one. So Jason Evstatio is joining us virtually, and Jason will explain us who is the patient who will never treat with the radiation therapy. So Jason, took the challenge. So we will see and we'll hear from him how we can move forward. So please, Jason, we are all very happy to have you joining us.
Great. Thanks so much, Andrea, and thank you so much for the invitation to this wonderful meeting. I just want to make sure, are you able to
yeah,
see
perfectly.
my slide? Okay, great. Well, it's hard to find a patient that isn't a candidate for radiation, but let me try and address some of the aspects that are being focused on at this meeting. So yes, okay, trimodality therapies supported by numerous guidelines for stage 2 and stage 3A disease. We know that. We also know that there hasn't been a randomized trial to cystectomy with neoadjuvant chemotherapy, which is the other category 1 recommendation. The best retrospective data out there suggests that when you have clinically matched patients, they can do equally well. This study comes from a multi-institutional study from Toronto, MGH, and USC. The eligibility was solitary tumors less than 7 centimeters, no or unilateral or only unilateral hydronephrosis, and no extensive or multifocal CIS. If you actually look at the cystectomy databases at Toronto or USC, for example, that would apply to 30% of patients that get cystectomies at those institutions. So 30% would have been eligible to have received TMT in this type of trial. And after propensity score matching, you can see a well-matched cohort. Yes, long-term outcomes in that selected population, such as metastasis-free survival, are very comparable between surgery and radiation. Again, if we're looking at a lot of series, this is the MGH experience. Really higher T stage, hydronephrosis, complete TURBT, as you can see here, have been not as well represented, right? They've either been excluded from studies or just not as well represented. And so radiation, chemoradiation, trimodality therapy has boxed itself a little bit into a corner of that quote unquote ideal patient. And yes, that leads to excellent complete response rates. And complete response, clinical complete response after chemoradiation is cysto and biopsy negative, urine cytology negative, imaging negative. And we have to, as Matt and others have got into, expand that definition and likely include things like ctDNA. But in this select population, outcomes are great. Yes, there are prognostic factors. So T stage, hydronephrosis, CIS, they're prognostic for outcomes. As we can see here, response, incomplete response in particular to chemoradiation, is associated with excellent results. And how, expanding that definition of how we define that and being consistent, as Matt said, is going to be key. But things like hydro and path stage are prognostic. They're also prognostic if you're undergoing radical cystectomy, as this slide here nicely shows. If you have T3 disease and hydronephrosis, you do worse also after cystectomy. So the question is, where do we actually draw that line? And then there's debate about the transurethral resection of the tumor, the TURBT. Some data has suggested better outcomes if you have a complete TURBT, but there's a lot of confounding here, right? Large tumors, for example, higher T stage. And there's this recent study out of a Canadian registry that said by adjusting for things like T stage, actually, you could get away with an incomplete TURBT. So having a complete TURBT is not necessarily a requirement. But we have to be cautious, right? So there are patient factors that are not good for radiation. Poor bladder function is a big one, right? There are consequences, as have been highlighted by other speakers, in terms of quality of life and side effects of treatment. And if your bladder function is poor to begin with, it's not going to be better after radiation. Certainly inflammatory bowel disease prior radiation. These are patient factors that are not ideal for radiation. The tumor factors, again, more locally advanced disease, bilateral hydro, large tumor burden involving the majority of the bladder, extensive CIS, diffuse or multifocal CIS, maybe a high-grade tumor in a bladder diverticulum, upper tract involvement of tumor, prostatic involvement, including CIS of the prostatic urethra. These are situations where we have to be a little bit more cautious. I'm just showing this here as we've addressed some radiology of muscle invasive tumor in a bladder diverticulum. Of course, this is going to be very difficult to have to resect. intravesically and may not be an ideal candidate for radiation-based therapy. What about node-positive disease? There is this retrospective UK study that said after cisplatin-based neoadjuvant chemotherapy, results seem to be as good between a radiation versus a cystectomy approach. So clearly there are select patients with node-positive disease that one could consider for radiation-based therapy. And if we turn to histology, we've addressed already CIS, extensive CIS not being ideal. And certainly urothelial carcinoma kind of is the mainstay for bladder preservation. But what if you have urothelial carcinoma with squamous cell features, right? So divergent subtypes. Retrospective data from my institution suggests that outcomes could be as good with these divergent histologic subtypes, but the vast majority of these are squamous or glandular differentiation for sure. This was recently validated by another Canadian retrospective registry study, large one, that again was primarily squamous and glandular differentiation, but actually had reasonable representation, for example, of micropapillary differentiation, some other things. And that similarly showed complete response rates, survival, need for salvage cystectomy, et cetera, was equally good between the divergent histologic subtypes compared to pure urothelial carcinoma. So certainly for squamous glandular differentiation, maybe micropapillary, but we really don't have data on plasmacytoid, sarcomatoid, and all these are retrospective small studies that have not been able to address all of these types of subtypes. Certainly, if the predominant histologic feature is squamous cell carcinoma, they do worse than urothelial carcinoma. That's been seen in NCDB and SEER studies like I'm showing here. And if there is predominant squamous cell carcinoma or adenocarcinoma, there are some studies that also suggest that you do better with surgery than with radiation-based approaches for those types of histologies. So certainly a lot of caution there, and I would recommend in those situations surgical approaches rather than radiation. Yes, we know from BC 2001, concurrent chemotherapy, radiosensitizing chemotherapy with radiation portends improved outcomes. And frankly, there's a number of active radiosensitizing drugs, lots of options for non-cisplatin candidates. And so that really, it's very hard to find a patient that would be unfit for concurrent low-dose radiosensitizing chemotherapy and should be used. A lot of debate about neoadjuvant therapy and neoadjuvant chemotherapy in particular. There's the BA06 trial that suggests potential benefit. There's this RTOG old study that was somewhat limited that showed no benefit. And I personally believe absolutely neoadjuvant therapy can be considered before chemoradiation. Certainly in situations with higher risk features, whether that be T3, T4 disease, certainly node positive disease, absolutely should be considered. And what we're discussing today is, how those patients respond to that neoadjuvant therapy, of course. And I think what we're going to see is, especially with the evolution of neoadjuvant therapy, a lot more good responses and actually opening up the eligibility to be consolidated with radiation-based approaches instead of surgical, as Sarah and others have addressed as well. Turning to the biomarkers, yes, there are molecular biomarkers that are going to help with clinical decision making, and certainly liquid biopsy circulating biomarkers that will help with surveillance. And in the world of bladder preservation, there's all kinds of biomarkers that have been looked at. These are largely retrospective series. Most are prognostic. Some may be predictive. Certainly, things like ERCC2 have been shown to be prognostic of good outcomes after chemoradiation, just as they have been with cisplatin-based chemotherapy. But I wanted to show you some data, and these are slides shared to me by Kent Mao on ctDNA after trimodality therapy. So this is sort of very preliminary data, and I think you're going to see a lot more data coming out about ctDNA with bladder preservation strategies and trimodality therapy series. And he'll be presenting this, I believe, at GU ASCO. But his data suggests about 40% of patients are positive for ctDNA prior to bladder radiation in this trimodality series. Clearly, it tips more to be positive if it's more advanced disease, such as T3-4 or N1 disease. In patients that were receiving neoadjuvant therapy prior to bladder radiation, some were actually negative before that neoadjuvant therapy for ctDNA, and then others converted from positive to negative. If you look at those, and this just shows you here kind of the conversion rate, right? So if ctDNA negative prior to trimodality therapy, they remain negative. If they were ctDNA positive, over half converted to negative, some remained positive in the longer post-trimodality therapy. And for those that remained positive, they didn't do well. I mean, many of these continued to have disease. There was one who had no evidence of disease and was alive without disease. And you can see that the level of the ctDNA actually may correlate with that. And so that's going to be very interesting to look at not only the level of ctDNA, but also the kinetics of change. And I think that's going to be an important area of exploration. Certainly, out of those that were ctDNA negative after bladder radiation, they did great. None of those that remained negative had recurrent disease. And also, none of the 5 patients who converted from ctDNA positive to ctDNA negative sustained a recurrence. So, this small series, and again, it's very preliminary, but about 40% of patients were ctDNA positive before trimodality therapy. 50% of those that were positive converted to negative. And patients who were persistently positive do poorly. This is an important biomarker, and those that are ctDNA negative really do quite well. And Kent has also talked about integrating perhaps ctDNA with other clinical genomic features, and also perhaps urine ctDNA. So you could imagine a situation where if after whatever treatment you've received, your plasma ctDNA and urine ctDNA negative, really maybe those might be good situations for surveillance. But if you're plasma ctDNA negative and urine ctDNA positive, maybe that's actually an indication for local therapy. And if you're positive in both circumstances, then further systemic therapy. So to kind of just wrap this up, I think, yes, trimodality therapy is supported by numerous guidelines in the US and Europe and elsewhere. In clinically matched patients, survival is comparable to radical cystectomy. Favorable prognostic factors tend to be unifocal T2, lack of hydro, no extensive CIS. But the presence of T3, hydro, and tumor-associated, so a little bit of CIS, is not necessarily a contraindication. These are prognostic. They're also prognostic typically after surgery. So we don't want to necessarily box ourselves in a corner. And with the emergence of more and more neoadjuvant therapy being given and expected responses in those scenarios, I certainly see the role for local consolidative radiation perhaps expanding. I think in the era, especially of neoadjuvant therapy, we have to think about is a complete TURBT required? I mean, generally the data says let's do a maximally safe TURBT. It should be at least attempted. I know Nick James might disagree with that, and we'll get into his talks later. But a visibly complete TURBT may not be required before bladder TMT. And especially in the setting, I think, of giving neoadjuvant therapy, we have to ask, how necessary is that? Concurrent radiosensitizing chemotherapy should be used with radiation if it's being given. And again, neoadjuvant chemotherapy and neoadjuvant systemic therapy should be considered, especially for patients with higher risk factors up front. And we should tailor their consolidative approaches, as has been nicely discussed by the other speakers. Patients that have urothelial carcinoma with divergent differentiation, squamous glandular micropapillary, probably have similar outcomes when compared to pure urothelial carcinoma and can still be considered for trimodality-based approaches. But if you have predominant squamous cell carcinoma or adenocarcinoma, you have worse survival outcomes. And I think those are not great candidates for radiation-based approaches and should be considered for more upfront cystectomy. And then, as we talked about at the end, validation of biomarkers in independent cohorts and prospective trials are so important. So all that ctDNA work is being built into prospective randomized trials that we're launching here in the cooperative group setting in the U.S. And that's going to be so important to kind of guide bladder preservation therapy and also for personalized treatment selection. And ultimately, and I think Rick said it, really best, and all the speakers have alluded to it, these patients, muscle invasive patients, should be seen in a multidisciplinary environment, and we have to safeguard their autonomy. And informed decision-making by the patient is key, not only on what local therapy they should be receiving, but how they should be treated after perhaps an excellent response to neoadjuvant therapy. And so with that, I thank you for your attention and really look forward to the discussion.
Thank you, Jason. Terrific, thanks. And a very nice story of the ctDNA. We'll hear also from Petros later on what the data will look like for in the neoadjuvant setting. So I'm very happy to open up the door to the last part of this session, which is the agency corner. We are very grateful to the people here and connected online. It's the first time in my experience to have the EMA side and the FDA side sitting down on the same virtual table discussing on the same topic. So it's my pleasure to introduce you Olli ten Hoonen, who is the vice chair of the Oncology Working Party of the European Medicines Agency. He will provide us with the regulatory authority perspective from the EMA side. So Olli, the floor is yours.
Thank you very much, and thanks for the invitation. I genuinely think we need this type of discussions and interactions together with the clinicians. So I have nothing to disclose in terms of industry, just to say that what I'm saying here, I'm doing it as an individual, so what I say here is not necessarily the official position of the European Medicines Agency, but rather representing my own views here. When you speak about regulatory perspectives in the EU, you don't actually speak about a single authorization or a single thing in that sense that the regulatory evaluation of a new drug is always a kind of a continuum, starting from the pre-authorization activities, clinical trial evaluation, which is mostly done on a national basis in the EU. However, sort of culminating at the marketing authorization as the kind of milestone of the regulatory pathway of a new drug. That is, in the majority of European countries, that is followed by the evaluation of the relative effectiveness of the product, the HTA, health technology assessment, and obviously, of course, the post-marketing surveillance. At the end, at different steps, we are still looking at the same protocols, the same trials, the same data, maybe from different points of view and slightly different angles, but anyway, it's the same trials at the end. And for the marketing authorization in Europe, it's the EMA that is responsible for the authorization for all anti-cancer products currently. The marketing authorization is based on an absolute concept of benefits and risks. So essentially what we do is we compare the benefits of the drug based on the studies to the risks at the time of authorization. This more or less in practice translates the benefits as efficacy of the product and the risks as safety of the product. So whenever the benefit risk is positive, the authorization is generally granted. And this doesn't, although we generally compare or like to see the drug compared to the standard of care or the best available standard of care at the time, this doesn't necessarily mean a evaluation of the relative effectiveness in that sense that we would compare the drug to all available treatment options. And that differentiates the marketing authorization from the HTA evaluation, for instance. There is a new pharma legislation package ongoing in Europe. I won't go into the details as it probably is not going to change the very basic concepts such as the benefit risk in the future. It might have some implications on the let's say in rare orphan indications and in rare drugs, possibly rare variants of bladder cancer, but otherwise the main principles will probably remain the same. Okay, coming back to the very question of today of trial designs and endpoints. We've obviously moved away from the very old thinking of different strictly thinking of drug development in phases, phase 1, phase 2, phase 3, and so on, or in strictly exploratory or confirmatory settings. However, I think even within the modern seamless trials and integrated study protocols, I think there are certain principles from these old concepts that still apply. So at the end, what you are aiming to show with your trial, it kind of defines the study design and endpoint. If your aim is to show the activity of the drug is somewhat different from the aim of showing a true clinical benefit and to use the data for as pivotal evidence for the marketing authorization. So in that sense, there is a difference between exploratory trials and confirmatory trials, and this is why I still like to use these sort of old-fashioned terms for exploratory trials and confirmatory trials. So if you wish to show an activity of a new drug, obviously you need to choose an endpoint that is related to the activity and an endpoint where the effect you see in your trial can be unambiguously attributed to the drug effect. And response endpoints like CCR, PCR, overall response rate, the advantage of response type endpoints obviously is that generally the effect can be attributed to the drug. We all know that the tumors do not disappear spontaneously in the absence of an intervention. Of course, there are complicating issues in let's say, in multimodality therapies or combination treatments where it might be difficult to know which part of the regimen is doing the trick, so the contribution of components question is there. You necessarily, the response itself is not connected to the safety of the product, so that is something that needs to be reported separately and is not captured by response rate endpoints. And the response, whether we speak about clinical response rate or PCR or overall response rate in the advanced settings, it should not be interpreted in isolation. So it is not only about the single digit or improvement or incremental increase in the endpoint itself, but it's also about the duration of response, and you may actually question that is a response to a certain type of pharmacotherapy, is it the same as to another type? I mean, is the clinical response to immuno-oncology drug, is it necessarily the same as a response to conventional chemotherapy agent? And obviously the time of the response assessment might be critical. When to do it in bladder, is it week 18 or later or earlier? It also depends on the type of the drug. So do not forget pharmacology when interpreting response rate endpoints. I have to say that I really like the comparison to biomarker type endpoints with the response rate that was mentioned in the previous presentation. I can see some concordance there. And I'm coming back to this later in the confirmatory setting, that how to assess the clinical relevance of a certain increase or increment in the response rate endpoints might be tricky, as we have seen the possible disconnection in the PCR rate with time to event endpoints in bladder cancer. So if we go to the sort of different clinical scenarios here that we have when we want to establish the benefit risk of a new drug in the curative setting of muscle invasive bladder cancer. And the first one is I think relatively straightforward when we compare the drug into the existing neoadjuvant or adjuvant scheme as a kind of replacement to the current standard of care, or as an add-on to the current standard of care. You have a comparator, you have a setting where you can randomize, and where time to event type of endpoints such as DFS or overall survival are feasible and also necessary for the regulatory decision making. Having said that, when you consider DFS or EFS as the primary endpoint in such a setting, here again the timing does account, and the maturity of data and the kind of point in the curve where you reach the plateau, so then you can be convinced of a durable effect. That is, of course, because the ultimate aim in a neoadjuvant or adjuvant trial is to increase cure rate, and we have to somehow extrapolate that from the DFS or ES endpoints. And obviously, that is why we are also always in the context of DFS and EFS, we are interested in overall survival data as a secondary outcome to outweigh a detrimental effect on overall survival. There are other issues, of course. This was touched yesterday already concerning the so-called sandwich design, which combined the neoadjuvant and adjuvant sequence in the early setting. This is an example, the very well-known example from breast cancer. You can imagine essentially every other neoadjuvant adjuvant trial instead of this picture, very similar design as in the Niagara trial in bladder. And indeed, this type of a design is not able to distinguish the contribution of different phases in the treatment sequence, meaning neoadjuvant versus adjuvant. As I said, the regulatory authorization is based on kind of absolute benefit risk. So if we are faced with such a design with a clearly positive BR, it's very difficult from a regulatory perspective to say that it wouldn't be approvable. But having said this, obviously there are ways by which you could tackle this issue, and it could have been studied simply by adding a third arm with the neoadjuvant only, or then applying a bit more sophisticated approaches by, let's say, re-randomizing the patients after the surgery to the adjuvant versus surveillance. There's a very much ongoing discussion around these designs, and maybe to take a formal position on this from the regulatory side is a bit premature. And it's a bit of a gray area, of course, in terms of exposing the patients to the continued administration of the drug. I won't go into the details of PCR in this setting. I will save that to my FDA colleague and for the next talk. Just to say that, as was previously mentioned, here again we come up face again the issue of the PCR in terms of the magnitude of the treatment effect, so that it's very difficult based on the existing data to say what sort of improvement in a PCR would be expected to translate it into a longer term benefit or benefit in time to event endpoints. Then the third clinical scenario, or actually a second one, where non-surgical option is compared to cystectomy. And this is a bit more tricky, obviously, because we are comparing two very different things to each other. They are complex, but not impossible from a regulatory perspective. And in these settings, you can randomize, even though you are comparing two very different things. Even for regulators, I think it's obvious that saving the bladder itself is a benefit. It is rather a question how the preservation of the bladder is transformed into a clinical endpoint and how it is measured in a clinical trial. Obviously, we are interested in hard endpoints, time to event endpoints in this setting as well, overall survival, preferably disease-free survival and so on. But here at the end, I would say that in essence, the time to event endpoints here kind of approach safety endpoints in that sense that the main idea is to exclude a non-detrimental effect compared to cystectomy. So we don't want to see the DFS or overall survival being compromised. But by doing that, we don't necessarily yet show the kind of benefit of saving the bladder. Also, EFS in this setting might be a bit problematic, especially in cases if you count salvage cystectomy in this kind of a design as an event in EFS, because in those settings actually you are very likely to fail if you have an EFS definition where the salvage cystectomy is counted as an event, although in certain ways it is a treatment failure in a setting where you wish to have the bladder preserved. And coming back to the third scenario, again, where we are comparing rather similar things, a bladder preserving option versus bladder preserving option, meaning in both cases TMT. I think we are rather open to a bladder invasive event-free survival as an endpoint here, as defined by Dr. Kamat there. Yet we don't have any regulatory precedents we know that it has been applied in a couple of trials, but we do not have any regulatory authorizations which would have been based on BI-EFS. The surrogacy obviously to overall survival remains to be established, and correlation as such, yes, likely there. Obviously there is the common S, so in survival in both endpoints, but whether it is a surrogate is methodologically, of course, a different thing. There again, the timing matters, the treatment effect matters, the plateau matters, and this might be, the timing of the analysis might be a bit complicated also here by the very different durations of therapy, where you, let's say, administer the drug for 2 years and have a TMT or CRT protocol where the treatment duration is about a month. So the timing might be critical. What I would also like to emphasize here, actually, whenever we look at composite type endpoints like BI-EFS, I think there is, for the regulators, there is the need to have an understanding which component of the composite endpoint is truly driving the treatment effect. And again, the ability of the trial to show that there's no detriment in the overall survival obviously is important even in this context. I won't go into the details of the methodological issues related to single-arm designs used as the pivotal evidence or confirmatory evidence for marketing authorization. These are obvious. However, I would like just to remind that don't simply look at the efficacy. It's always the other part in the package, which is the safety. And if you do not randomize, you generally also lack comparative safety data. Study populations and patients' eligibility to TMT or cystectomy and refusal, these were all touched in the previous presentations today. Just to say that from a regulatory perspective, these populations might be tricky as we generally require unambiguous definitions for ineligibility for something and for refusal of something, and populations that mix patients refusing cystectomy and ineligible patients might be rather difficult to interpret from the regulatory perspective, being heterogeneous at the very beginning. And these also obviously have reflections on the study design, what sort of study design can be applied if you have these two rather different populations within the same protocol. As being unambiguous is for regulators important simply because at the end we have to sort of transform the population and the trial into an indication wording of the new drug. We also discussed earlier today the eligibility for TMT, ineligibility for cystectomy. Maybe the answer is that there is a population that is eligible for bladder preserving options but not eligible for cystectomy. But just to be as unambiguous as possible. Again, I won't go into the advanced setting. I will save that to my FDA colleague if she has further views on this. I would just say that in general, the general regulatory principles of advanced malignancies also apply in in the advanced metastatic setting of muscle invasive bladder cancer. Are the regulators requiring too much? I think it's, it depends on the point of view. It took a while before the neoadjuvant chemotherapy became the global standard of care. And what do we have there? We have maybe more than 11 randomized studies. We have several meta-analyses. We have a convincing overall survival benefit. So that's food for thought, what we require at different stages of drug development and when introducing new treatment modalities. So to conclude, at the end, what you are aiming to show and where in terms of the clinical setting is a basis for the study endpoints and study design you should choose, whether you are planning to show early activity of the drug, whether you are aiming to show true clinical benefit in terms of as pivotal evidence for marketing authorization. Sometimes in certain cases the activity and benefit may turn out to be the same thing at the end. Generally, when we speak about muscle invasive bladder cancer, we from the regulatory point of view, what we would like to see is randomized time to event data. There are several aspects that highlight the sufficiently mature overall survival data, whether it's coming from the primary endpoint or the secondary endpoints. At the end, it's the data that counts that allows you to exclude a non-detrimental effect on the overall survival, so that it can be reasonably concluded that the survival and cure is not compromised compared to standard of care. There are specific challenges in terms of endpoints in these different clinical scenarios, and it's not only about the name of the endpoint, it's also about the magnitude of treatment effect, how to define the margins of non-detriment or non-inferiority and superiority. I have a bit of a dislike for the term totality of the evidence because it's often used in cases when the regulators themselves don't know what to ask. But in this case, I think it still sort of applies that you have to take the whole package into account. And innovative designs, re-randomization, such approaches can be used to try to tackle the open questions we have, for instance, in terms of the neoadjuvant adjuvant type of trials. Thank you.
Thank you so much, Ollie. I mean, that was a very detailed, thorough talk, and I also like the way you candidly shared some insights with us. I know there's a lot of questions that we want to ask you, but we'll wait until the designated time. Next, it's my distinct pleasure to welcome to the forum and the stage Elaine Chang, who's going to be representing the FDA group. I do want to publicly acknowledge how the FDA over the years and the team that's on, Dan Sussman, Hannah Weinstock, Sandeep Agarwal, Halle Falal, truly the group and others who weren't able to join us today over the years, and this many of us in the room knows, goes back to 2014, 15, 16, when the whole BCG unresponsive definition was coming up. And truly the folks that are on and others reached out to us as a bladder cancer community at the AUA, at ASCO, at the IBCG, and the whole BCG unresponsive definition changed, and now we have so many drugs approved and on the way to be approved, which is phenomenal for our patients. And over the years, this group, and Elaine's going to represent the group today and give us a talk, has truly partnered with us for the benefit of our patients, right? I mean, they have been essentially the regulatory hurdle, but appropriately so. And I think it's really remarkable to see the partnership that has ensued between the FDA, this group, all of us here, patient advocacy groups. And again, Elaine, welcome and thank you.
Thank you so much for that amazing introduction. I should check. You can hear me?
We can hear you, we can see you, but we can't see your slides yet.
Okay. Let me share my screen. Can you see my slides now?
Good to go. Thanks.
Okay, great. Thank you again for that amazing introduction and for the organizers for allowing me to join this important discussion. I am a medical oncologist at FDA, and I work in the Division of Oncology 1, which regulates the products for the treatment of genitourinary cancers, which include bladder and other cancers. And I have no conflicts of interest or financial disclosures.
Elaine, you were sharing dual screens. It's good now.
Oh, sorry.
It's good now.
Okay. Let me.
It's okay now.
I didn't advance
it went away.
But I think I didn't advance my slide. Did I?
No, it's not advancing.
Okay.
It is now.
Yeah,
Great.
okay. In the next 18 minutes, I will review the regulations and precedents under which we at the FDA operate when reviewing trial designs to support regulatory decision-making. And this part will include oncology approvals across tumor types in non-metastatic settings with an emphasis on endpoints in regulatory decision-making. And I will briefly address a few considerations for externally controlled trials. I'll also share lessons learned from mismatch repair deficient or microsatellite instability high locally advanced rectal cancer, a unique situation where there is an ongoing single-arm trial utilizing a surgery-sparing approach with clinical complete response as a primary endpoint that has been proposed to support a future marketing application. And then I'll end with observations on the challenges and opportunities of the non-operative management paradigm in muscle-invasive bladder cancer, including a concept for using clinical complete response to identify a lower risk patient population. So I would like to begin with a broad view of FDA regulatory thinking. While the EMA discussed both exploratory and confirmatory trial designs, my presentation will focus on trials intended to demonstrate substantial evidence of effectiveness. And just to note that EMA's use of the term confirmatory is more similar to FDA's use of the term registrational trial, and not how we at the FDA may say confirmatory in the context of accelerated approval. To demonstrate efficacy of a treatment, a randomized trial is always preferred when feasible. Randomization ensures balance of both known and unknown patient or disease factors that may influence study outcomes. Randomized clinical trials also may have other beneficial design features, such as blinding, to reduce bias. OS can be used as an efficacy endpoint, but tumor-related endpoints can be considered as early efficacy endpoints that are clinically relevant in advanced cancer. In oncology, single-arm trial designs and response endpoints may be used to establish efficacy of an investigational agent. Response rate is a marker of drug activity because malignant tumors do not typically regress on their own. This endpoint can be interpreted in single-arm trials for monotherapy oncology drug regimens where disease is present at baseline. In rare situations, an externally controlled trial may be used, which I will address later. For trials in early non-metastatic curative intent settings, FDA has typically requested randomized controlled trials comparing the investigational therapy to standard of care, or the investigational agent as an add-on to standard of care, with approval based on established endpoints of clinical benefit, such as disease-free survival. In GU cancers, similar to the EMA, we also generally expect to see no detriment in OS, although the study does not necessarily need to be powered to demonstrate an OS advantage. In the absence of a comparator group, results of time to event endpoints are considered uninterpretable. An exception to this paradigm has been durable complete response, such as the basis of traditional approval of investigational therapies for BCG unresponsive, high-risk, non-muscle invasive bladder cancer with CIS. The considerations for durable CR evaluated in a single-arm trial in this curative intent setting to support approval originally included the lack of suitable comparators for randomized trials. And as we know, standard of care cystectomy is curative, but it is associated with morbidity and mortality. The public stakeholder discussions in 2013 with FDA participation on endpoints, trial design, treatment assessment, and follow-up led to an FDA guidance that described FDA expectations for an adequate data package, which was issued in 2018 and updated in 2024. The 2024 guidance acknowledges the availability of more recently approved standard of care treatments for patients with BCG unresponsive non-muscle invasive bladder cancer, allowing for a randomized design, and explicitly states that a randomized study is preferable and can provide stronger evidence of efficacy and safety. Now I'll discuss in more detail another aspect of trial design, that is endpoints in regulatory decision-making. The FDA guidance International Conference on Harmonization E9 document states that there should be sufficient evidence that the primary variable, primary endpoint, can provide a valid and reliable measure of some clinically relevant and important treatment benefit. While this is a simple statement, there are several key components of this criterion. There should be a valid and reliable method of measurement for the endpoint. Additionally, the endpoint should assess a clinically relevant and important treatment benefit. These fundamental considerations should be kept in mind when thinking about the adequacy of a clinical trial endpoint. There are two types of endpoints we use in oncology for regulatory decision-making. The first is clinical benefit, which is a positive therapeutic effect that's clinically meaningful in the context of a given disease. This may sound vague, but I'll go over concrete examples of clinical benefit endpoints in the next slide. Then there are intermediate clinical endpoints, which are measurement of therapeutic effect that can be measured earlier than morbidity or mortality and are deemed reasonably likely to predict clinical benefit. There are multiple endpoints that have been used in oncology drug development. Listed on this slide are several common oncology endpoints and their advantages and disadvantages. The key regulatory considerations are whether it captures a direct clinical benefit, the risk of bias when being assessed, and the feasibility in its use as a primary endpoint. I'll point out a few important aspects. For OS, overall survival, it can be measured easily and precisely and incorporates both safety and efficacy information. It can be affected by crossover within the trial or subsequent therapy apart from the trial. Thus, large treatment effects may be needed to demonstrate an OS benefit. And depending on the disease setting, the trial may also need to be long. Like all time to event endpoints, they cannot be accurately assessed in single-arm trials. Progression-free survival and event-free survival can be measured earlier than overall survival, but are subject to bias and may not always correlate with OS. Response rate is also an endpoint that can be measured earlier and requires a smaller sample size, but does not incorporate safety, and again, may not correlate with OS. Clinical outcomes such as PROs may be clinically meaningful, but the trial design and statistical analysis plan must be carefully designed to minimize bias and address relevant questions. While clinical CR may demonstrate activity of a drug in the same sense that response rate does, our current discussion is focused on an early disease setting where it's still unclear if the clinical meaningfulness of clinical CR in a curable patient population is similar to that of response rate in a metastatic population. We're not sure at this point if clinical CR means that one can avoid cystectomy or radiation and still achieve the same outcomes. So clinical CR does not yet have the same feasibility as response rate apart from time to event endpoints such as bladder intact event-free survival, which again require randomization for interpretation. Clinical CR also has significant potential for bias, and an area of need will be how to reduce bias in the trial design, which I will discuss in more detail later. In summary, when considering any endpoint and its use in a specific trial, it is important to consider the context of a particular patient population, treatment setting, and intercurrent events. Another discussion related to trial design, particularly when considering single-arm trials, is externally controlled trials, which I was asked to discuss. I would like to point you to a recent draft guidance published in 2023 referenced on this slide. I'll go over some high-level points from this guidance. An externally controlled trial is defined as one in which outcomes in participants receiving the test treatment according to a protocol are compared to outcomes in a group of people external to the trial who had not received the same treatment. One key takeaway from this guidance is that before selecting an externally controlled trial design, one must consider the likelihood that such a design would be able to distinguish the effect of a drug. For example, if the endpoint of a trial is bladder intact event-free survival, in a comparison between an intravesical or systemic therapy versus chemoradiation, cross-trial comparison or comparison to real-world data would be challenging due to many factors such as intercurrent events that the results could be uninterpretable. There are potential differences such as patient preferences for treatment receipt or variations in standard of care that could create challenges to comparability between the investigational and external arm. In summary, externally controlled trials is a nuanced topic, and we highly encourage sponsors to consult FDA early and often to discuss whether an ECT or other trial modernization approaches would be reasonable. An illustrative example of another tumor type where clinical trials are also attempting to use clinical CR as a primary endpoint in the setting of a non-operative paradigm for early stage disease is mismatch repair deficient or microsatellite instability high locally advanced rectal cancer. A phase 2 single-arm, single-center trial evaluating the effect of dostarlimab in this population reported a 100% rate of clinical CR in 12 patients. And as an aside, these data were updated this year and continue to demonstrate CR of 100% among 42 patients. The sponsor at that time proposed a future marketing application data package comprising 2 single-arm trials, both with clinical CR at 12 months as the primary endpoint. Secondary endpoints would include CCR at 3 years, event-free survival at 3 years, and overall survival at 5 years. This approach would be precedent-setting and thus warranted a discussion by FDA's Oncologic Drugs Advisory Committee, ODAC, even before the second trial was initiated. ODAC was asked to discuss and vote on whether the data from the proposed single-arm trials would be sufficient to characterize the benefits and risks of dostarlimab in the curative intent setting for the proposed population. The vote was 8-5, with the majority of ODAC voting in favor of the single-arm approach, as alternative standard treatment results in long-term life-altering effects. Key discussion points included that given the unprecedented efficacy reported and availability of off-label dostarlimab and other PD-1, PD-L1 inhibitors on the market, ODAC felt that a randomized trial was not feasible. However, the advisory committee discussion highlighted some major concerns, including that the proposed primary endpoint clinical CR at 12 months may not provide long-term assessment of clinical benefit, such as prevention of metastatic disease, which is critically important. This is one of the most important points that needs to be emphasized when considering clinical CR for bladder cancer. For robust benefit risk assessment, we need to understand if there were any missed opportunities for cure with non-operative management. Metastasis-free survival, bladder intact event-free survival, and overall survival all require a comparator for interpretation. Committee members also noted that patients were interested in non-operative management largely because of morbidity associated with definitive therapy, and therefore quality of life data in a non-operative approach should be meticulously collected. Important to note in this situation is the already reported efficacy of dostarlimab in this patient population, a 100% CR rate, which is very unique. Now, I'd like to address more specific considerations around clinical trial design for bladder-sparing strategies for MIBC. As we've heard, there is marked heterogeneity across studies evaluating non-operative management paradigms for MIBC, leading to uncertainties that should ideally be addressed before initiation of large trials evaluating this approach. These uncertainties include the fact that the optimal clinical response definition has not been defined, differences in accuracy of imaging modalities available, and feasibility of blinding some components of assessment methods are also concerns. Current assessments may rely on operator-dependent cystoscopy results, which is vulnerable to bias. And we have heard that from our discussions with sponsors that ensuring local and central pathology on the same tissue can be challenging. We also acknowledge, as we have also heard earlier in this session, that ctDNA and utDNA may potentially have a role in improving the accuracy of identification of patients with no residual disease radiographically. While clinical CR does not inherently capture durability of response or survival, bladder intact event-free survival may be able to incorporate these considerations into its definition. A question that we could address during the next panel discussion is how time to event endpoints such as bladder intact event-free survival could be defined and perhaps refined to capture clinically relevant time for those who choose not to proceed with surgery or chemoradiation. Perhaps there is clinical relevance of a durable clinical CR in itself. And if patients find clinical CR followed by a prolonged treatment-free interval to be clinically meaningful, this would be incorporated into the bladder intact event-free survival definition, and benefit risk can be supported by secondary endpoints such as metastasis-free survival. However, an important potential weakness of bladder intact event-free survival is as an endpoint that FDA has discussed before is that the decision to proceed to cystectomy can be subjective. The objective triggers for cystectomy should be clearly pre-specified in the protocol, and reasons for cystectomy should be collected in the case report forms. A key question to us is whether randomization is feasible. If early results of a therapy demonstrated a high magnitude of response, close to 100%, I could foresee that randomization may be challenging, but we have not seen this scenario in bladder cancer, as far as we know, thus far. Lastly, if the premise is that non-operative management results in better quality of life, this also needs to be rigorously assessed, which requires a randomized design. We must remember that the investigational treatment itself has toxicity, and follow-up cystoscopies and other procedures do come at a cost to patients. I have discussed the concern that complete clinical response may not capture a meaningful treatment benefit, and this is a potential weakness as a primary endpoint for regulatory purposes. A path forward to using clinical CR may be using it as an enrichment strategy, biomarker, an eligibility criterion to select patients who may be particularly suited for a more conservative treatment paradigm. As mentioned earlier in this session, the one-size-fits-all approach may result in over and under treatment of certain patients. A more biomarker selected approach has the potential to optimize benefit risk for appropriately selected patients. So after a definition of clinical CR is supported by prospective assessments of clinical validity, a randomized trial would be needed to evaluate new investigational therapies in this population because there's no tumor at baseline to indicate a drug effect. A potential design could be to randomize patients with clinical CR to bladder-sparing approaches, including surveillance, systemic therapy, and systemic therapy with radiation. Major outcomes of interest would be event-free survival, where events would include both local and distant recurrences. We could call it bladder intact event-free survival. A key secondary endpoint should include overall survival, which is both a safety and efficacy endpoint. It would also be important to incorporate a rigorous assessment of safety and tolerability if the hypothesis is that avoidance of definitive therapy will lead to an improved patient experience. While I am suggesting that this could be a potential approach to evaluate a non-operative strategy for muscle-invasive bladder cancer after clinical CR, this would still be a novel trial design, which may require much discussion with the FDA and potentially an advisory committee discussion as well. In conclusion, assuming equipoise exists, randomization should generally be used whenever feasible, because this provides for the best assessment of benefit risk. FDA approvals in early non-metastatic curative intent settings generally rely on randomized trials and are based on established clinical benefit endpoints. FDA has an interest in developing novel endpoints, but these endpoints must be valid and reliable measures of clinically relevant and important treatment benefits. We have noted some challenges with clinical CR. To highlight a few, the reliability of the endpoint and potential for bias, and uncertain clinical meaningfulness in a population eligible for surgery or chemoradiation. Trials evaluating clinical CR should ensure long-term follow-up to assess durability of response and safety. Investigators and sponsors should meet with the FDA to discuss trial designs early, including trial designs that use clinical CR as an endpoint or as a biomarker. And if an application is submitted to FDA based on a trial with a novel endpoint of clinical CR, it may need to be discussed at ODAC Advisory Committee. I would like to acknowledge and thank many people, including the organizers, again, patients who continue to participate in trials and contribute to scientific advancement of the field, and many at FDA who have contributed to this presentation. And happy to answer questions now.
Thank you so much, Dr. Chang. I mean, hearing from you and then from you, Ollie, I mean, there's just so much that we have to work on, which is the next part of this thing this afternoon. We would like to have a coffee break, but obviously we would also like to have questions. So we're going to limit it to 2. And let me call on, I'm taking a risk here, calling on Dr. Grievous first, but let me do it anyway. Petros, you're up.
Elaine and Ollie, thank you so much for being here. This is Petros Grivas from UW, Fred Hutch Seattle, here in Milano today. My question to you is specifically regarding the definition of the event when we talk about event-free survival. And I asked this question to you because I had the honor to discuss Niagara at ESMO, and I noticed that about 6% of patients are selected to not undergo radical cystectomy. And if I remember, Elaine, FDA guidance was to count those as an event. So my question to you is that the recommended option going forward? We hear from Rick Banks and others that patients want to keep their bladder. Should we count those if it's not toxicity related and not cancer detection related? Is the right approach? I don't know if it's right or wrong, but should we recommend that to count as an event? Thank you, both of you, for being here and all you're doing to support us and our patients. Thank you. Elaine, maybe you can go first and then Ollie.
In general, for many endpoints and in trials for registrational purposes, supporting marketing applications, we often request many sensitivity analyses. And so I don't think that there necessarily is a straightforward answer to the question. I think we would generally ask for justification from the sponsor to explain why they propose a certain definition for the endpoint, including their censoring versus event rules. And then we try to use consistency across applications that have the same endpoint. I think this is a more new area, and so this can be an ongoing discussion going forward.
I don't think I have much to add to what Elaine said here, and might be a bit difficult to take a position concerning a single trial and a single example. Event-free survival is a difficult endpoint in that sense that sometimes you have events which do not necessarily represent the event actually they were initially thought to represent. I mean, in this sense, it's the event is not a treatment failure, and that's what makes it tricky. And if the amount of such events is high, I think we can end up with difficulties in the interpretation. As long as the number is relatively low, as in your example, I think the data remains interpretably irrespective whether you count them or not.
So
I think
sorry, Elaine.
sorry, to add on to what I was saying, we asked for multiple sensitivity analyses and we expect to see similar results across the sensitivity analyses. So assuming that the treatment benefit is robust, the sensitivity analyses and the primary analysis should all show similar results. If there are very different results across sensitivity analyses, then we may start to get concerned, and that would be something we would take into consideration. So we would take all the data into consideration, but we would expect that if the drug is really having a strong effect, that we would see that clearly despite different definitions.
Thank you.
Thanks. And again, just to summarize, sounds like you're saying case-by-case basis, can't make much based on the Niagara study itself. Second question and last question for this part, Dr. Powell, Monty?
Yeah, sure. Thanks again for terrific presentations all around. Elaine, I'm glad you brought up PROs, and some of the speakers had touched on that. And one of the things we're trying to do today is really improve the cumulative patient experience, right, really across the continuum of MIBC. And as I think about, some of the presentations we've had, Shilpa's great EV302 talk last year, Checkmate 274 data, across most bladder studies, we're looking at generalized quality of life measures, right? Like the QLQC30 or the EQ5D metrics, and they really don't capture the experience of the bladder cancer patient in any way, shape, or form. I mean, if we were to work towards optimizing PROs, I realize we're still at risk for some degree of bias, but I mean, is that anything that would ultimately be incorporated in a regulatory decision?
Yes, it could be. So we do have a PRO guidance on core patient reported outcomes. I think we often will encourage sponsors, we generally encourage sponsors to meet with us if PROs will be an important part of their drug development plan. So if they intend to make any claims, like an efficacy claim, like time to deterioration of certain symptoms, then we definitely would want to see that that they have a good plan in their statistical analysis plan for the definition, collection of the data, and how they will handle missing data. And then it is possible that we would put that in the label. There's also recently an example that we have included PROs in the safety section of the label. So those are all possibilities, but again, case by case basis, we would encourage sponsors to meet with us.
From the European side, I think we have a kind of a relatively conservative and generic reply to the question on PROs, that they are generally considered as supportive evidence rather than sort of pivotal evidence for the marketing authorization or benefit risk assessment. However, we do acknowledge that this, coming back to the issue of how to measure the benefit of saving the bladder, it is something that where we take all the supportive evidence genuinely, I think, into account as a measure of benefit. In terms of labeling or inclusion of this data in the product information, we generally say that we do not prefer to include such data from open label studies, but then again we are dealing with studies which cannot be really blinded when we compare very different treatment modalities, and the very different toxicity profiles and different nature of the control treatment is an issue also from the PRO perspective, because how do you, in terms of PROs, how do you compare cystectomy to, let's say, adverse events of immune checkpoint inhibitors or something like that? So very difficult to give a definite answer here.
So for the virtual folks, please feel free to text your question on chat. So we are constantly monitoring the situation there. So we are more than happy to take your points and your questions. I have a question for both of you regarding possibility to overcome anyhow the need to have a randomization design. We will see from the statisticians from Irina and the last talk what could be a design for a possible study in this regard. But from your standpoint, provided that we could identify a patient population for which we do not have actually a standard of care, an established standard of care, but we do have some real-world data suggesting that a certain patient management could be an option, or is an option in real world. Is there a way of accumulating data in real world and using this data instead of making a randomization? What do you think, Olli?
Again, maybe Elaine had examples of the so-called externally controlled trials. Maybe the European side is a bit more conservative here. We generally say that at least in the context of pre-authorization advice, that the external data is mainly used for contextualization, and the data itself needs to be self-standing, coming from the single-arm trials. This, however, doesn't preclude in certain situations an authorization based on uncontrolled data, but generally requiring very strong justifications where it would be applicable. Here I can only refer to the reflection paper that was mentioned in my slides, which lists the issues and efficacy considerations for single-arm designs.
Thank you, Elaine. Do you foresee any opportunity here for such a kind of design of non-randomizing patients or so? What do you think?
I acknowledge this is a challenging situation, and I think that there are also a lot of challenges with the externally controlled trials. So we would have to see if there is a way to really identify a reasonable single arm or externally controlled trial approach, and the sponsor would have to meet with us. I will say that as far as the control arm goes, the regulatory standard is not that there needs to be one single standard of care. So maybe to take an example from non-muscle invasive bladder cancer, the options to patients include cystectomy. Maybe there are also off-label intravesical chemotherapies that are used. So there are different options, and then it's a discussion between patients and their provider. And we have told sponsors that the control arm just should be a relevant option for patients. So it doesn't need to be necessarily the best option that is a universal consensus.
Thank you.
Can we do one more question, Dr. Gupta? Last one.
Really great session. Thank you to all the speakers, and thanks, Elaine. So my question was around the bladder intact event-free survival. Like all the current studies are using 2 or 3 year as the primary endpoint. Do we think that is a surrogate for long-term overall survival, or what is the right endpoint that the FDA considers? Is because there is really no data on where that number came from. We just
So you were saying the number being 2 or 3 year?
right.
Okay. So in general, across disease areas, our statisticians discourage landmark analyses as the primary analysis. We recommend hazard ratio, log rank analysis, and that will take into account the whole curve, the whole treatment benefit across the time range, whereas a landmark is one snapshot in time. And there are cases where there have not been that many events, and so we will report maybe a landmark as a descriptive, the descriptive analysis in a label. That's not the primary analysis.
Thank you.
Ollie, do you have?
Not much to add. Referring to what Elaine said, I think clinically the timing is critical in that sense that we have sufficiently mature data and understanding where we have reached a plateau, which is considered sort of a measure of a long-term benefit, and at the same time have sufficiently mature overall survival data as a secondary outcome to exclude the non-detrimental effect. Of course, methodologically, it's not that obvious when and how to exclude a non-detriment on overall survival. As for surrogacy, I think methodologically, surrogacy and correlation are a bit two different things. So formally, we cannot speak of surrogacy here.
Elaine and Ollie are giving such useful responses that I'm going to take chairperson's prerogative and eat into the coffee break. If anybody wants to step out, feel free at the back or at home, grab some coffee. But we'll have 2 more questions. Let's do first from Betsy Plamack. If you're still on, Betsy, please ask your question.
Yeah, I hope you can hear me. Thank you for providing the opportunity for us to participate by Zoom, and these have been great talks. I just wanted to reflect on bladder intact event-free survival as an endpoint. And Elaine, you touched upon this, that the events of disease, recurrence, metastases, and death are objective, but the decision to recommend cystectomy, especially for patients on the active surveillance arms of our retained trials, and Matt, I know on your trials as well, is very fraught, very subjective, and really without data. In addition to cystectomy, there are the options of BCG for non-invasive disease and trimodality therapy to salvage these patients, which in our experience, and you'll hear more about that from Dan, many patients chose. So since we are likely to have to advance this approach with a single arm design, would we, and this is a question for the regulators, would we strengthen our argument by sticking to event-free survival as defined by disease or death?
So the current design is, what is the current endpoint?
I'm comparing bladder intact event-free survival, where cystectomy is considered a failure, which is a decision that we make, not necessarily based on a lot of data, compared to narrowing that to event-free survival as, metastasis or death.
So I think that we would look at all the data, but you should definitely, if you think that this has regulatory implications, then you should request a meeting with us. I guess my interpretation of the difference between an objective endpoint like metastasis-free survival and the bladder intact event-free survival or disease-free survival would just be that there are a few additional ways that a person could have an event for bladder intact event-free survival, because there may be reasons other than progression or or recurrence that lead to a cystectomy. And so those other reasons, I don't know if this happens that frequently, but if patients just have non-functional bladders and, like Rick mentioned earlier, that maybe they're urinating so frequently that quality of life is impaired, if that is happening frequently as a reason for cystectomy, then it might affect our interpretation of the trial. So these are more possibilities that I've wondered about, but anybody who has more insight into this is welcome.
From our side, I would hand over to Dr. Francesco Pignatti, who is also representing the EMA here. Just to clarify, were you speaking about single-arm design here?
Yes, I think we're going to be forced to do a single-arm design to advance this concept. My opinion, I think some of what we've heard support that just because of the difficulty in randomizing to, life-altering surgery. So my question is more around the proposed endpoint of bladder intact event-free survival. And I understand it can't be answered directly on this call, but might we strengthen the relevance of a single-arm trial if we stick to more objective measures of event? The decision to undergo cystectomy seems to be less objective.
Yeah,
Francesco.
It's definitely very challenging to have this type of endpoint in a single-arm trial, particularly because it will be difficult to attribute causality to some of the components of this composite endpoint. But of course, we never say never. So again, if there are extreme results observed, yes, even in that setting, you might be able to show something. Or if you had extraordinary, well-curated external comparators that allow you to make interpretations of the difference you observe, then, well, never say never. But it is a very challenging road that you're planning your path.
Betsy, I think you have raised a very, very valid point, and it will be very important to hear from the next presentation. For example, the pathways and the landscape of type of relapses in the Medgalski study, in your study, in the Retain study, to see if we are able to make some fine tuning also on the endpoints to use in the bladder preservation strategy. Last question from Maluf, and then we will close the door.
My question is to Elaine and Noily. We heard from the prior presentations that a complete clinical response is not a perfect endpoint because patients may recur and may recur quite quickly. So my question is, with the advance of the radionomics and also the ctDNA, so we are improving the evaluation of what is a really, really clinical pathologic response. So if we prove that with all these modern methodologies, a clinical complete response means that the patient is probably cured, do we need to still look for overall survival or progression-free survival as the endpoint, or could we stick with this modern, accurate endpoint, which is much easy and pretty quick to assess?
Elaine first.
My understanding of the question is that the clinical complete response could be more accurate with radiomics or other tools. And do we need overall survival?
Yes.
To be assessed?
Yes.
So I think that we still need the data. So for any trial design, like we've been saying, we would want you to meet with us to discuss the specifics of that investigational therapy and that trial design. But I don't think at this point we can assume that the long-term clinical benefit endpoints, such as metastasis-free survival or overall survival, would be improved. And those endpoints can help also capture safety. So I think the accuracy of clinical CR is one thing, but we still need the long-term data to understand what that clinical CR means for the patient in the long term.
Only?
Yeah, the brief answer would be that we are not there yet. You never know about the future and the evolution of different methodological approaches. We generally, in the European context, we do not kind of pre-authorize or pre-qualify necessarily certain endpoints or certain designs. It's at the end, it's the data at the time of authorization that counts. Just to say that there are examples in hematological cancers where, for instance, minimal residual disease has been applied for quite some time already in different trials, and we still do not have a complete clarity how it should be interpreted in the clinical, in the regulatory context. So you don't know about the future. We hope that we see novel methodologically improved response endpoints, and as being said, being there methodologically and technically as accurate and as predictive as possible is always a good thing and a good way forward when developing these approaches.
Thank you, guys. So great discussion. So let's take a 10 minutes break. We are running a bit late, 10 minutes late. So we will take 10 minutes for the coffee break and see you in exactly 10 minutes. Thank you.
Yeah. Right. But you know, the 2 or 3 year, like, has somebody proven that that is a surrogate? That's what I don't know. You know what I mean? It's a randomly decided endpoint. Did somebody say something to you? You came up.
Just wondering if we're still on a break here?
Yeah, we will start in 1 minute. We are
No problem, no problem.
getting
Thanks.
to the room. Thank you. Thank you for waiting. So hi friends again. So let's restart. So we are running a bit late, so that in order to avoid further delays, we'll start the second part of the meeting. So the roundtable discussion has been conceived with the special agenda on this, in order to save time to touch the topics that we thought were most important to discuss together, and we will leave, of course, much discussion on this. So we will start with the presentation of the poll that we did within the IBCG group that we ran in the last 2 months. This poll was intended not just clearly to provide a consensus within the consensus, but just to frame the context prior to start the discussion, and to present you the sense, the feeling of the IBCG community towards special topics, special questions that we deliver to them, so that basically the idea and the principle that we apply to this poll were the same that we usually apply to IBCG poll, without, importantly, any need for revoting procedure, because again, we are not generating consensus here. The disagreement for sure is much welcome, and we will provide the background for the next discussion. So 64 guys responded to the question. The first question was this one: the novel bladder preservation approaches with experimental perioperative therapies should rely on a stringent definition of clinical CR. We have already touched on this point, and the vast majority of the people were in agreement to this point. So the definition, to having a shared, a very, very particular definition of clinical CR. Second question is within clinical trials, the CCR definition should include the combination of all of these factors: negative cross-sectional imaging, negative urinary cytology, and negative biopsy, most importantly. Again, there is a strong agreement on this, so the inclusion of a multifactorial definition of clinical CR. One question to which we didn't get any consensus was the following one: any residual non-muscle invasive tumor, including CIS, PTA, PT1, high or low grade, should disqualify for clinical CR. There will be room for discussion about this, and Ashish will chair the next discussion session. Fifth question is the tumor stage and completeness of diagnostic pre-therapy TURBT should be accounted for in the definition of clinical CR. Well, we almost achieve a consensus here. There is uncertainty still. We are pretty much familiar with this bias, and we as oncologists are always reminded asked by urologists, that there is an impact on radicality of TURBT on the situation of the patient prior to starting neoadjuvant therapy. So this is a point to consider also when looking at the situation after the neoadjuvant therapy. Pelvic MRI and VIRATs. So I see Giorgio here and then Larry. Should be preferred over CT scan. There is uncertainty here, reflecting that the need may be to have more standardized criteria in the sense that more widely applicable criteria, so more widely...
Andrea,
yeah.
Unfortunately, looks like this screen is not being shared with our Zoom audience. So can
Oh
we
my God.
share the screen and then unfortunately restart it?
So are you able to see the slides?
They're not. That's what's coming up on the chat.
We can see it. No, you don't have to restart it.
Yeah, we can see it.
A
Did
few
you see
of you
my-
can't see it. Maybe refresh your browser at your end, the ones who are telling us you can't see it. We have to.
So I didn't understand if you have seen my slides until till now, or if I have to restart. Did you see
You
my
don't have to
slides, my
restart.
previous slides?
So Jonathan said if you could, are you able to see the slides?
Yes.
Yes.
Okay, yes.
Okay, so some can, some can't. Maybe just refresh your browser.
Changing the view, how you view this, the presentation, or pin the browser.
You can pin it to your, instead of having it in the box, little boxes.
All good now.
All good now? Great, okay.
Okay, so let's restart. Question number 7. Tumor and liquid biomarkers are still immature to be incorporated into the definition of clinical CR. We'll hear from Liang Cheng and Petros about the urinary tumor DNA or ctDNA. There is an agreement of using these tools as a biomarker part of the study, not put into the definition of clinical CR. Question 8, all patients diagnosed with MIBC should be offered an inclusion in a clinical trial. The majority of the responders were opted for yes. GFR between 50 and 60 should not disqualify patient to receive standard neoadjuvant chemotherapy. So standard of care chemotherapy is still there, with the Niagara paradigm, you know. And in fact, here we have a consensus. Opportunities for bladder preservation, this is an important point to me. Depending on response to neoadjuvant therapy, should be discussed a priori with the patient, so prior to start any neoadjuvant therapy. So it's not something that should reshape based on the quality of the response the patient achieve. It should be ideally discussed prior to start treatment. Opportunities for bladder preservation, depending on the response to neoadjuvant therapy, should be offered to patients who are qualified for radical cystectomy. This is another important point. So we are here discussing about the bladder sparing opportunity, basically in patients who are qualified for radical cystectomy. Opportunity for bladder preservation, depending on the response to neoadjuvant therapy, should be offered to patients who are unsuited for or elect not to undergo radical radiotherapy. So going back to Jason's point and to the standard of care that is still there worldwide with chemoradiation. So identifying patients who are refusing at a certain point radical cystectomy, but at the same time for which radical radiotherapy is not the primary option, let's say, for them. Agreement of 88%. Opportunities for bladder preservation, depending on the response to neoadjuvant therapy, should be considered if a maintenance consolidation therapy is offered within trials. So there is an agreement. So the position of the majority of the responders is towards a tail of maintenance therapy instead of observation. We'll hear from Dan Gainsman and the RETAIN study what is the situation for observation alone after clinical complete response. Cisplatin eligibility and the role of standard neoadjuvant therapy should be considered in the design of bladder sparing perioperative trials using experimental therapies. The majority said yes, 90%. Cisplatin eligibility, so still considering the potential standard of care there, that is a neoadjuvant cisplatin-based chemotherapy. Neoadjuvant cisplatin-based chemotherapy followed by RTORBT and observation should be considered a standard of care approach for patients who refuse cystectomy after neoadjuvant course and refuse or are unsuited for radical radiotherapy. So going back to the question that I've raised to the regulators before, what is actually the standard of care? That what we do currently in the daily practice in patients who refuse radical cystectomy after standard of care. There is uncertainty here. There is not an agreement. So the position is not for the majority of the responders to go to observation alone after the patient have achieved a deep response. Based on result of the Niagara study, neoadjuvant Durvalumab-Cis followed by RTORBT and maintenance durvalumab should be considered a standard of care approach in patients who refuse cystectomy after neoadjuvant Durvalumab-Cis and refuse or are unsuited for radical radiotherapy. So again, here, doesn't matter if we add durvalumab to standard of care chemotherapy. The point is that the majority of people within the IBCG were skeptical about using this paradigm as a standard of care approach for patients refusing cystectomy. Clinical complete response endpoint is ready to be used as a co-primary endpoint for next generation bladder sparing trials. We will hear also from Irina and the statistician in lecture, but there is not a consensus about this. Event-free survival, we have discussed about this, should capture any time of tumor persistent recurrence progression during follow-up, along with the receipt of any additional standard of care treatment like radical radiotherapy. The vast majority of people said yes. So an all-inclusive endpoint here. Clinical complete response and DFS are adequate co-primary endpoints for setting new standard of care with next generation trials. There is skepticism here, not a consensus, less than 70% said agree. And the last question is evaluation and the reporting of patient-reported outcome should be required, going back to the question by Monty, should be require a secondary endpoint of trials of bladder sparing approaches. The vast majority of the people said, yes, I agree. So let's open up the door with Ashish to the discussion with the floor. Thank you.
Thank you very much. So as most of you have been part of the IBCG efforts, you know that we do this by consensus online anonymized voting because we've all been on guidelines panels where, of course, you know, somebody can drive the whole discussion and we don't want one person to sort of influence a consensus panel, right? So that's why we do this, just to answer some of the questions that were asked in the break as to why are we doing this by online voting. And we're going to have a series of talks today, and we'll resend the questions out to the members, just the ones that didn't have consensus. But for the purpose of this discussion, and in the interest of time, I'm going to go backwards a little bit and go to the ones that did not have consensus, just to see if there's anyone that wants to raise a point or a counterpoint while we have everybody's attention here. So for this one that did not get that 75% consensus, complete clinical response and event-free survival are adequate core primary endpoints for new standards. And this sort of refers a little bit to, Fernando, your question earlier. I'm not assuming that you are the one that agreed or disagreed, but anybody have a comment on this that they want to make while we have everybody's attention? Any questions? Anyone online or here?
I suppose I'm not sure whether this is part of the answer, but I'm wondering whether the challenge with the definition, the stringent definition of clinical complete response, to Matt Galsky's point, whether that may have generated, you know, that skepticism about inclusion of CCR as a registrational endpoint.
Absolutely. I suspect that is the case. And for those that feel one way or the other, this is your opportunity to either strongly agree or strongly disagree. Okay.
Maybe a question from a regulator here. You've defined them as co-primary here. We often see in the regulatory setting trials where two endpoints are suggested as dual primary endpoints, meaning that if either one of them is positive, you can claim success of the trial. But you seem to consider these as co-primary, which would methodologically mean that they both need to be positive in order the trial to be successful.
make a comment. Clinical complete response has not been defined yet. So this could be the reason of the disagreement. And so we should do that before taking into account the answers. So because there are some who think that complete response could be better defined. This is what I think. For instance, we didn't talk about lymphovascular invasion at the very beginning of TOR. This is a very important step. Yesterday, I just contacted the guy who presented the ctDNA, and the correspondence between the two tests are about 70%. So if we have a lymphovascular invasion in the beginning, we can imagine that probably we're going to have also tumor cells in the blood. So this is a thing that we've never been considered in the complete response stuff.
Very valid point. Betsy, Dr. Plimak?
Yeah, it's just, I think I disagreed here only because and Matt made this point in his talk really well, that CCR is not in and of itself what we're going for. It's not meaningful to the patient. What's meaningful is long-term outcomes, ideally without toxicity and with the bladder intact. So keeping the focus on that, I think the endpoints should reflect that, and we should consider CCR as a tool to help us decide who is a good candidate for bladder sparing. And then that gives us room to define CCR in all the rigorous ways that we're all trying to do. But that's why I would take it out as the endpoint.
I think we lost our shared screen. If we could go back, because I just, question 17 also was about CCR, and there was not consensus there, and I suspect 17 and yes, the other question are correlated. So this is one that is something we're going to discuss in the next several talks, because we really need to see if we can define CCR in a way that would convince those that disagree with this as a relevant endpoint as to whether we can use it today or we still are months, years, or never get there, per se.
Sorry, Shishi, let's make the counter argument, Yeah, I agree that there is disagreement on clinical CR, but is anyone against, in principle, the definition of getting the paradigm of clinical CR used, for example, in Megalski study, using biopsy negative assessment, cytology assessment, negative assessment, cross-sectional imaging negative. Is there anyone who is against this approach, or is suggesting a different model for defining clinical CR? Because otherwise, it seems to be that there is a consensus actually on to use a clinical CR this way. Is anyone against this definition for clinical CR?
Not against, but I don't think we've nailed it down. I don't think we've defined ctDNA's contribution to it, and we'll talk a little more about that in Dan's talk, but.
So would you be
tricky?
Okay.
So, I mean, I think we should keep trying to evolve it. I think it's good the way it is, but I don't think it's ready. And Seth, I think, made this comment in the chat also. It's not ready for an end.
Seth, do you have a comment as well?
Well, I just put it in the chat, and I think Betsy's making the point, and I agree with it, that there's a tremendous opportunity in our clinical trials to look at it as a, whatever you want to call it, secondary, exploratory, but, I sense that there's some agreement, Andrea, to what you're describing about using all of the tools available to us to define clinical CR and test that prospectively. I just don't think that we have that data to include it as a co-primary endpoint. I mean, look, it's hardly validated. Path CR is hardly validated. There was a whole consensus conference that Andrea Paulo and Elaine and others led, and my God, I remember sitting around that table. And granted, that was a while ago. The lack of consensus, even at that time, were the hard endpoint. So we've made a lot of progress since then. But so I think that just in designing our clinical trials, we should be looking at an opportunity to test and validate that so that it can be used as a co-primary endpoint in the future.
Hey, Seth, I was wondering if I can ask, I think many people on that panel, because I think that's one that was hinted at, but I also sort of struggle with this. Is there a time-sensitive component related to defining a complete response? And what I mean by that is obviously if someone's received neoadjuvant treatment of some type, you know, where do you set the stage, whether you use biomarker? I know we're defining how do we use biomarker, what's a true, you know, complete response from a biomarker standpoint, but also that time-sensitive component, much like other tumors we treat, that when you sort of should set that benchmark and saying, okay, this is when we take all these criteria and identify whether they meet that criteria. Any thoughts on that?
Well, other than thinking about it right now, it's a good point. I mean, I guess the corollary is CR in BCG unresponsive disease, CR, quote, at any time, right? Within the first 12 months, I think, as some of the clinical trials have used. And I think there's some vagueness about that that's concerning to some of us. But that's a different disease state. So, you know, I think that the way our current clinical trial, 1806, is designed is that, Jason, correct me if I'm wrong, I think it's around sort of an 8-week plus or minus 1 week after completing the radiation therapy, and we require biopsy. So one could argue that at least we'll have, sorry for the noise in the background, cytology, and biopsy to go on. We have pre-treatment imaging. You know, there's lots of opportunity there. That trial was designed back in 2017, 2018. We'll have ctDNA, thank goodness. But I don't know, Jason, that there's necessarily consensus around that timing, but it seems to make sense. But you probably have a better handle on that than I do.
Yeah, no, I'm totally with Betsy and Seth. I think in trimodality therapy that it's about 8 to 12 weeks, let's say on average about 10 weeks following completion of radiation, where that treatment assessment response is done with a cysto, biopsy of the tumor site, cytology and imaging, and doing it much sooner than that, you know, you can find some sort of false positive results, so where basically not enough time to achieve maximal response has been given. And obviously one doesn't want to go too much later than that, like 2 to 3 months following completion of treatment. So that has sort of been the sweet spot for trimodality therapy. But overall, I totally agree. I don't think clinical complete response is ready to be a primary endpoint at all, but we absolutely need to build it into prospective randomized trials, define it the same way. And I think if that comes out of this meeting, like a very clear definition of what it is, and it's actively built into developing and ongoing studies, then we would hopefully achieve, you know, be able to prove surrogacy, that it serves as a surrogate endpoint for the more meaningful disease outcomes. And so, yeah, I would also love to see MRI being used as much as possible for the cross-sectional imaging, and I would love to see ctDNA with all the emerging data being included in that definition. And I think if those things pan out, we'll have a very robust definition of clinical complete response that would likely achieve surrogacy.
And absolutely, Jason. I mean, that's the whole purpose of this workshop here, and we're going to hear talks on that have data and slides. And absolutely, I think that's what the question about that was. So we showed those consensus statements backwards first in some ways to just kind of refocus everyone's attention on why we're here. Durva, yes, no, that's different. In closing, because we do want to go on to the next one, but I do want to let Matt make a point. Matt?
Thanks. Those are all great comments. I just want to make the point that I do think we're still going in circles a little bit on endpoint versus biomarker. Biomarkers are developed in a purpose that's fit for that in a manner that's fit for purpose, right? So all these different scenarios are tied to different clinical decisions, and those clinical decisions require different considerations. So understanding if chemoradiation has quote unquote worked is a very different situation than trying to decide if you can leave someone's bladder intact after 4 cycles of systemic therapy. They're not the same thing. We shouldn't treat them the same.
Thank you, Matt. So let's move now to the next section, which is aimed to provide the quick updates from key trials in this field. The RETAIN study that will be soon released online as a full manuscript, and the Metgalski study. So 10 minutes each. Then Genisman will start first with the RETAIN study, showing us the type of relapses, treatment partners, and outcomes. So then the floor is yours, and the 5 minutes discussion will follow.
Great, thank you. This has been a wonderful meeting, and thank you for the kind invitation to present really our work. I'm gonna work on sharing my screen. And can you just confirm that you guys can all see this?
Yeah,
and hear me?
perfectly. Yeah.
Thank you. Okay, so I will try to stay on time. And I think the clinical question that was posed to us was really what happens to patients who have NMIBC post-neoadjuvant therapy or who recur with NMIBC after going on to active surveillance post-NAC. And I will touch on that and just show the data from RETAIN as well as some overall data. And as you mentioned, this will be available, I think, on Monday in JCO, the full manuscript, if you wanted to take a look. So this is not, of course, meant to be read. This is simply an abstract for your reference. And so I will skip that. And just remind
So then,
everybody-
I'm sorry to interrupt you. Just to note for an housekeeping note, all the abstract that you kindly wrote for the meeting will be shared in a shared folder together with the slides of today's meeting. So all the material will be made available to all of you, and it will be part of the manuscript that we will generate. So I'm sorry, please.
Great. Yeah, perfect. And that's why I think we can skip the verbiage here, and it's sort of for posterity's sake. So just to remind everybody, this was the design of RETAIN 1. And let me just go through that. The patient, of course, had their original TURBT and had a diagnosis of muscle-invasive bladder cancer. And that tissue was sequenced in RETAIN for 4 DDR mutations, ATMRB1, FANK, and ERCC2. And then they went on to accelerated MVAC, 3 cycles. And following that, went down to a TURBT number 2. I just want to make the point that that second TURBT that I wrote here was really a mapping TURBT, really pioneered by Alex Kudikoff at Fox Chase. And that was already mentioned once in one of the papers published by Matt Zibelman. So it was really a mapping TURBT. And following that, patients had an option of going on to active surveillance, that's the top box, if they had no residual tumor, i.e. clinical T0, the best that we can figure out, and had one of these 4 mutations, either a pathogenic or a VUS. All other patients, as you can see, were slated into sort of other buckets, and these included intravesical therapy for those with non-muscle invasive disease, chemoradiation for those with muscle invasive disease, or cystectomy also for those with muscle invasive disease. And as you can see, there was some flexibility and there was a choice for patients and physicians to make the decision together. So this was the design of the trial. And we had 102 patients sign consent. Treatment actually started in 78, and the ITT population was 70. And so what you can see here is that out of those 70 patients, 45 were mutation negative, or they had some residual disease, and then 25 were mutation positive and had no residual disease. That is the true per protocol active surveillance group. But you can see, interestingly, that even in those who were mutation negative or had some residual disease, not everybody went on to definitive bladder-directed therapy. So not everybody got chemoradiation or cystectomy. You had patients choose to go on to intravesical therapy. This is again showing sort of the real-life scenario, and I think echoing what we've already heard, which is patient preference and focus on quality of life and bladder preservation, which is so important. And then let's take a look more sort of specifically what happens to these patients. So if you have the mutation negative patients, so this is divided slightly differently, 37 of them, I just want to focus that the majority did go on to a cystectomy, 26, 6 had chemoradiation, and then there were actually 3 patients that began BCG for non-muscle invasive disease, and to the best of our knowledge at our last checkup, all 3 are NED. There were 2 that also began active surveillance, not per protocol active surveillance, because they were clinically T0 at their second TURBT, mapping TURBT, although they did not have any mutations, and one of them did unfortunately have metastatic disease. If you then flip and look at the mutation positive patients, you can see that again, 25 were not only mutation positive, but had true clinical T0 disease and all started surveillance. But there were other patients, like 4 patients, who had non-muscle invasive disease and again began BCG. And out of those 4 patients, 1 has developed metastatic disease, 3 are NED. And actually, 1 patient, mutation positive, has still T1 disease, went on to active surveillance, and has remained disease-free. So really, this is the key slide, I think, and we can spend most time looking at that, happy to go back to that. But this really shows the 25 patients who went on to, per protocol, active surveillance. So again, had a mutation, were clinically T0, and really their course. And what you see are on the right, the alterations that they had, and then the different colors represent various scenarios. So for example, in purple is development of non-muscle invasive bladder cancer. In blue, little diamonds is muscle-invasive bladder cancer. In red, importantly, is development of metastatic disease. And then you have a black box that's death, and a green circle is cystectomy. So really looking at this, you can have different scenarios. So for example, you can have a patient who went on to active surveillance, remained in active surveillance for some years, then developed non-muscle invasive bladder cancer, had some form of intravesical therapy, and remained with their bladder intact. On the flip side, you have a patient like this who went on active surveillance, developed non-muscle invasive bladder cancer, had some form of therapy for that, and then unfortunately developed metastatic disease sometime later. And finally, you have a situations, and I'm focusing on non-muscle invasive because that was really the question for me. You have a patient, for example, like this, who developed non-muscle invasive bladder cancer, had some therapy, then went on to a cystectomy, and then developed metastatic disease. So we can sort of go through some of these, but if we sort of look more and try to summarize the data, what happened is out of the 25 active surveillance patients, 17 did develop some recurrence. And if we look at their first recurrence, 10 out of those 17 had non-muscle invasive recurrence, of whom 3 have died or developed metastatic disease. 6 out of 17 developed MIBC as their first recurrence, of whom 5 have died or developed metastatic disease. And 1 out of 17 really immediately developed M1 disease and died, and who, as I think has been alluded before, probably would not have been helped by a cystectomy anyway. And then if you focus even more on the 10 patients who developed non-muscle invasive bladder cancer recurrence, 3 out of 10 have developed M1 disease. No one has died yet, but they have developed M1 disease. 4 out of 10 retained their bladder with intravesical treatment, and no one has died or developed M1 disease. And then 3 out of 10 have had to have a cystectomy, none died, and none have developed M1 disease. So that's sort of the breakdown. If you look, and this wasn't the focus, but I wanted to put that in because we're talking about endpoints and landmark and hazard ratios. So this was, of course, a single-arm study, and we did have a landmark endpoint of 2-year MFS, and what you can see here on the left is that for the ITT population, the 2-year MFS was 73%. And if you divide up the patients and those who went on active surveillance or not, that's on the right, that number is 76 versus 71.1%. And if you look at overall survival, it was approximately 84% at 2 years for everybody, 88% for those who went onto active surveillance, and 82 in the non-active surveillance group. So again, I think as we're thinking about what do we do with patients who go on active surveillance and then develop recurrence, I just wanted to show these patterns of relapse in some detail in patients who went on active surveillance and then developed M1 disease. And so here are 9 patients who started with MIBC, went on the Retain trial, and then what happened to them later. So you have someone who went, for example, on trial and then developed M1 disease a few months later. You have 3 patients who develop NMIBC after going on to active surveillance and then unfortunately have metastatic disease. And then you have some patients who develop first muscle invasive disease, have a cystectomy, for example, and then developed metastatic disease. Okay. But I think in all of these patients, other than one, what I think is important is before development of metastatic disease, they all had some form of bladder recurrence, whether it's non-muscle invasive or muscle invasive recurrence, they've had recurrence, which I think at least to us indicates that one has to be really aggressive in those patients who develop recurrence in their bladder if they're in active surveillance. And this slide, I will stop talking, and this is a slide that Betsy Plimek had put together beautifully, and so I will let her speak on this slide.
So thank you, Dan. Apologies for shoehorning this right into this talk, but I do think it's relative to a lot of the conversations we had before. When thinking about how to guess at PT0 at cystectomy, using all the things we talked about, we sort of put some numbers around it for sensitivity and specificity. We used studies where everyone had a cystectomy. So it compared what you see here, biopsies, mapping biopsies, NGS, ctDNA, and MRI to cystectomy. We excluded the initial VIRAD studies, which correlated the surrogate endpoint to TURBT, and we excluded most of the Driscoll data because we couldn't define PT0. So again, we focused on PT0 at cystectomy as the correlative point. And what was interesting to us and somewhat disappointing in looking at this is that none of these has a clear sensitivity advantage. They are all highly specific. So in other words, all of these sort of different ways of guessing at PT0, which parentheses is not the ultimate endpoint, but an important intermediate endpoint, all of these fail in the same way in that disease can hide from us. So it's, pretty good at finding, knowing that disease is there. It's unusual we predict disease will be there and it isn't. It is common that we predict disease would be absent and it is there. And I think this is the conundrum around the data we have right now, using the modalities we have right now in terms of predicting PT0. So Dan and I just wanted to share that. I'll turn it back to him.
Thank you. Again, this is, I think, very important to this discussion in how we move the field forward. So I just want to mention that Retain 2 has already been completed and the initial results will be presented at GU ASCO this year. And the trial looks, of course, very similar to Retain 1, but one important difference is that patients received nivolumab immunotherapy in their neoadjuvant therapy, not just chemotherapy, although there was no adjuvant immunotherapy. And so I think this will be important data to take a look at as well. So I think in summary, persistent or recurrent NMIBC after neoadjuvant chemotherapy can be aggressive. About 14% of patients with NMIBC immediately following NAC in Retain who went on to intravesical treatment developed M1 disease. That's what we can say from this small data set. About 30% of patients who went on active surveillance after neoadjuvant chemotherapy and then developed NMIBC, then developed M1 disease. Okay, so about 30% of patients who develop NMIBC while on active surveillance ended up having eventually metastatic disease. Again, small sample size, but I think an important number when we think about what do we do with those patients. And so, as a clinician, as somebody having a patient in front of them, of course, we want to preserve the bladder. patients want to preserve the bladder, but I certainly get very nervous when I see this. And I think aggressive local therapy, whether with cystectomy or potentially chemoradiation or potentially better intravesical therapy, is important. And of course, combining that with other biomarkers such as ctDNA will be critical. So that is the end of my presentation.
Thank you, Dan. Great presentation, terrific. So we are running a bit late, so we have time for just one question.
So Dan, let me ask you, because this is very sobering, right? And if you look at the timeline, it almost seems like the recurrence of non-muscle invasive disease in this patient cohort was incidental to them actually going on the way to get metastatic disease. And that's why like a more composite endpoint rather than what happens at a static endpoint would be more relevant. But my question to you is, and you might be able to glean this even though it's small numbers, in those that had a non-muscle invasive recurrence and then had a cystectomy in the cohort that you presented, was the residual disease at cystectomy at the site of the non-muscle invasive disease? Because it almost seems like these patients were understage and the NMIBC was incidental.
That's a great question. I don't have an answer for you. Where in the bladder the muscle invasive disease was in comparison to where the NMIBC was. I think that we could potentially try to take a look at that, but it'll be challenging, I think, to know exactly because of lack of uniformity in sort of reporting, I think, exact sites at that point. But I think that's an important question. Yeah, I don't have an answer.
I think we're going to move on. Thanks. I think, Dan, congratulations to you and to Betsy. This very, very sobering data, but I'm glad we're able to sort of share it with all of us. We're going to move on to Matt's next talk on updates from SCRN GU16257 types of relapses, treatment patterns, and outcomes. Matt, thanks again for being here and for sharing information related to this trial.
Thank you. And once again, can everyone see my slides? Yep. Okay.
Yeah.
Thanks. Okay. So as we've already discussed, we know that a subset of patients with muscle invasive bladder cancer can achieve durable bladder intact disease-free survival with transurethral resection of bladder tumor followed by systemic therapy. And of course, we've known this for quite some time, but this has not become part of our standard treatment paradigm. And as I already mentioned, I think these are the key barriers to advancing this paradigm. We've had a paucity of prospective studies, lack of rigorous methods to measure and define clinical complete response, limited understanding of the role of delayed cystectomy in patients with local recurrences, we just heard, suboptimal systemic therapy, and perhaps the absence of biomarkers to refine decision-making. So it was really with those concepts in mind that in around 2015, we designed this study to try and address some of those barriers. And this study was a multi-center, multi-investigator effort. And I just want to highlight John Svakianos, Monty Pollins, Sia Danishman, who were instrumental in getting this done. So HCRN 16257 enrolled patients with muscle invasive bladder cancer. Patients underwent transurethral resection of bladder tumor. That was followed by 4 cycles of gemcitabine cisplatin plus PD-1 blockade with nivolumab. And after those 4 cycles, patients underwent clinical restaging, and that was defined by cystoscopy, mapping biopsies, urine cytology, and imaging, which included MRI unless otherwise contraindicated. Patients achieving a clinical complete response, which I'll describe on the next slide, had the option to proceed without cystectomy and proceed with 8 more cycles of nivolumab. That was the Q2-week dosing, so 4 more months of nivolumab. Or they can undergo cystectomy. And I'll just highlight right now that only one of those patients opted to undergo an immediate cystectomy. Patients who didn't have a clinical complete response were recommended to undergo cystectomy. And the endpoints of this study were really designed to try and address much of what we were discussing earlier today. So one, we wanted to define what the clinical complete response rate was using a stringent and uniform definition of clinical response. And 2, we wanted to understand what clinical complete response told us about longer-term outcomes in those patients. So to assess the performance characteristics of this biomarker, if you will. And in terms of assessing the performance characteristics, we assessed the positive predictive value of clinical complete response for this composite endpoint of 2-year metastases-free survival in those patients who opted to not undergo immediate cystectomy, or path CR in the patients who achieved a clinical CR who underwent an immediate cystectomy. I already mentioned to you that only one patient underwent an immediate cystectomy. So really what we were comparing was whether or not clinical CR told us about 2-year metastases-free survival. And the reason that was the endpoint was related to these comments earlier about the fact that we want to try and exclude a detriment in outcomes in cancer control. Ensuring that patients survived without developing metastatic disease was of course a primary concern. In terms of assessing clinical complete response or clinical response, what I already mentioned to you, we use cystoscopy, biopsies, imaging, urine cytology, mapping biopsies, as I mentioned, in MRI, and a clinical complete response was defined as patients who had no evidence of cancer on any of these assessments. So we enrolled 76 patients, 72 underwent clinical restaging. Of the 76 patients, 33 had a clinical complete response. So the clinical complete response rate was 43%. Of those, 32 opted to forego immediate cystectomy. 1 patient underwent immediate cystectomy. And then of the patients who didn't achieve a clinical complete response, you can see there the majority underwent protocol recommended cystectomy. Some patients opted for bladder sparing approaches off study. This swimmer's lane plot highlights the outcomes of the 33 patients who achieved a clinical complete response. This includes 1 patient who had opted for immediate cystectomy. That patient had a low-grade papillary tumor on final pathology. In the swimmer's lanes, the patients in the dark blue lanes indicate patients who've had no local recurrence. The arrows at the end indicate that patients are still alive. The patients in the light blue lanes indicate patients who had a local recurrence. The red boxes indicate local recurrence. The yellow boxes indicate cystectomy. And again, the arrows at the end indicate patients are still alive. So you can see 1 patient who achieved a clinical CR developed metastatic disease without local recurrence. That was an unusual situation. The patient developing malignant ascites as the sole site of metastatic disease. No evidence of disease in the bladder confirmed by cystoscopy at that time. And then you can see these patients who achieve local or experience local recurrence followed by cystectomy. And I'm going to go into more detail about those patients. The positive predictive value of clinical CR for 2-year metastases-free survival was 97%. And you can see the metastases-free survival curves stratified by clinical CR versus not. The timing of these local recurrences, of course, is important, and as we think about designing studies moving forward and the frequency of assessments, you can see that the local recurrences peaked at about 10 to 12 months after study entry. So that's probably about 8 to 9 months after completing the initial period of systemic therapy and undergoing clinical restaging, and then started to decline after that. And this Sankey plot indicates the outcomes of patients who achieved a clinical CR. So you can see that in patients who achieved a clinical CR and developed a local recurrence, and we specified per protocol any invasive any high-grade local recurrence, patients should undergo cystectomy. And so you can see that in patients who experienced a high-grade local recurrence, and underwent a quote-unquote delayed cystectomy, the final pathology here, there was 1 patient who had a path CR in that group because the cystectomy was actually triggered by imaging rather than by cystoscopy. There is a nuance here that I think we need to think about in terms of just documenting when we do clinical trials in this space in the future. And that is that we need to report consensus pathological staging at the time of cystectomy, because there are patients who have a restaging TURBT when they're diagnosed with local recurrence. That might be a T2 tumor. Final cystectomy is T1 residual disease. And of course, that final pathology should reflect a consensus of the TUR plus the cystectomy. You can see here that there are a couple of patients who developed local recurrence that didn't have a cystectomy that included a low-grade papillary tumor, and then one patient who developed CIS who did not proceed with protocol recommended cystectomy, had BCG, and is without evidence of disease. And so, of course, there are some differences between the limited data sets in this setting that we've seen so far, and of course, multiple potential explanations for this: patient selection, sample size, treatment regimens, the clinical response assessments that are employed in the definition of clinical complete response. And I think importantly, as already highlighted, the approaches to management of bladder recurrences in patients achieving a clinical complete response. So local recurrences will occur in a subset of patients with clinical CR after TUR plus systemic therapy. Quote unquote salvage surgery has played a key role in organ preservation strategies across all organ sites. Whether definitive local therapy at the time of local recurrence compromises cancer control versus upfront local treatment for all does require further investigation. In the threshold for proceeding with definitive local therapy and specific definitive local therapies applied in that setting need to be standardized to advance a risk-adapted, individualized treatment strategy. So thanks for your attention.
Thank you, Matt. Terrific. Is there any burning question?
What is the follow-up, Matt, of these patients now?
Sorry, I meant to mention that during the presentation. I meant to mention 2 points, which I failed to. One was that this is a prospective study with certain data locks. And so what I showed just now is what's in the public domain. Our second data lock, the data from the second data lock is now being prepared for publication. The data that I showed you was with a median follow-up of 30 months for patients who achieved a clinical CR.
Matt, Petrus here, great work, my friend. Really important trial for the field. If I remember correctly, when you came to Seattle, I think you look at DNA damage response, gene mutations, other biomarkers, and I don't think this added value in predicting long-term outcomes in addition to the clinical complete response. Is that right?
That's correct. And sort of my explanation for that is a relatively simple one. Having strategies to predict the future are not all that helpful when the future has already occurred. What I mean by that, of course, is that if someone's already achieved a clinical complete response, knowing their likelihood of achieving a complete response doesn't help you quite as much. So perhaps let me qualify that. There was a higher likelihood of clinical CR in patients who had ERCC2 mutations. But the likelihood that patients would achieve 2-year metastases-free survival did not differ in patients who had clinical CRs with ERCC2 mutations or not. So potentially helpful from the start, but less helpful at the time of clinical restage.
Jonathan, do you have a question?
No, I was just going to make a comment on that, Matt. I think your point is well taken, but you've used one biomarker to then analyze the performance of other biomarkers. And I sort of wonder if you start the other direction, whether you would necessarily end up with the same results and how using imaging and clinical complete response actually intersects with this. And are there other folks who, it sort of argues that there shouldn't be any biomarker strategy. Obviously, it also suggests that our biomarkers are insufficient, which I think is clearly true at the moment. There is one other study that hasn't read out in any meaningful way, which is the Alliance trial, trying to do a similar thing with a slightly different biomarker panel. And I think, the study is accruing reasonably well, and hopefully we'll see some results where we've gotten I think around over 200 patients enrolled at this point.
So let me qualify my comments. Additionally, in that was a secondary endpoint of our study. We were not powered to assess whether or not the biomarker added the DNA damage response gene mutation biomarker added to clinical decision making, and certainly we're underpowered for that. So we didn't see that it clearly helped, but our study is not the study to address that question.
So we do have a question from Andrea Polo, and then we will skip to the next presentation. Andrea.
Thank you. Hey, Matt, a question that I had was, did you have any variance within these patients? And the reason I asked that is you said one patient didn't have anything in the bladder and then developed ascites. I'm wondering, did that patient have plasmacytoid variant histology? Were there any patients, was that a criterion for enrollment? Did you look at the variants?
Yeah, so there had to be a majority urothelial, sort of the usual sort of 50% thing that we've used in trials in the past. And that patient did have some plasmacytoid variant on initial pathology.
Thank you. So let's move to the next presentation. Jason will replace Nick James in outlining the type of relapsing treatment partners and outcomes after standard chemoradiation protocol. So it would be interesting to see what is the situation, what happens after the standard chemoradiation protocols in bladder saving approach. So Jason.
Great. Can you see the slides and hear me okay?
Yeah, yes.
All right. So unfortunately, Nick couldn't make it to the meeting, so he asked that I present his slides. So please, I'll try and add my own commentary as well. But Nick's talk was to be on patterns of recurrence and outcomes with bladder preservation. And, I think he, oops, sorry. Can you still see the slides okay?
Yes.
Okay, great. So he wanted to start off with kind of distinguishing UK-style bladder preservation from perhaps what's been termed trimodality therapy, look at some long-term outcomes and also patient-reported outcomes in his talk here. And so his first point was that not all chemoradiation is sort of classic trimodality therapy. The UK has been more sort of permissive in terms of kind of eligibility for bladder preservation, certainly. Trimodality therapy traditionally has been, the maximal TURBT, no CIS, no hydro, good bladder function, good response to the first part of therapy. And we kind of went over that in my earlier talk. That being said, I think that, we are becoming more pragmatic and permissive with trimodality therapy and are expanding indications. And I think I sort of suggested, a little bit of that in the earlier talk. But, classically, and if you go back to the original RTOG trial, certainly was a very select population. And it was really ensuring that those keeping their bladder had lower stage and was sort of excluding poor responders to treatment. Also, the typical age in sort of American bladder preservation trials have been in the sort of mid 60, early 70-year age range. Historically, it's been only about 10% of bladder cases in North America, but again, I think that has certainly been expanding. And historically, I think it's been more as an alternative to surgery in cystectomy fit, mostly younger patients. And I think what Nick's point here was that, yeah, if you look at some of the surgical series, certainly they're younger patients, but in the UK trials like BC 2001 and Beacon, in general, the median age of the patients are older. So this is kind of the classic RTOG schema for trimodality therapy that was sort of a split phase, an initial induction course, an assessment response, and then consolidation. But again, I think as I've highlighted previously, that has evolved, and most sort of US-based bladder preservation is single phase, single course all the way through to full dose these days. In the UK, however, again, they're a little more permissive, I think, and have had broader eligibility historically. And so there hasn't necessarily been that requirement for maximal TURBT. And we addressed that in the earlier talk. I mean, I think still maximal TURBT is very valuable, but it doesn't necessarily have to be visibly complete TURBT. And I showed data to that earlier. CIS is more tolerated, I guess, in the UK, as long as it's not too extensive, but about 20% of US-based bladder preservation have had some tumor-associated CIS. So not extensive, not multifocal, not diffuse, but just a little bit is okay. Hydronephrosis is generally not viewed as a contraindication in the UK. And I think, for example, that multi-institutional cohort, Zlota publication, did allow unilateral hydro, but I think in the UK, they're even more permissive on that front. Generally, it's single course treatment, similar to here. And then, salvage cystectomy is used for local relapse or non-response, which is pretty standard. And it's viewed as the mainstay of therapy for older patients, plus as an alternative to surgery in younger patients in the UK. And more than 50% of muscle-invasive patients in the UK are actually managed with chemoradiation approaches, which I think has to be the highest worldwide in any national sort of practice patterns. So here is kind of the UK approach to bladder preservation. Generally, an assessment of fitness for neoadjuvant chemotherapy is done. If they are fit, they're going to get cisplatin-based chemotherapy. If they have not had a good response, they'll go to cystectomy. If they've had at least a partial response, they'll get chemoradiation. If they're not fit for neoadjuvant chemo, they'll get chemoradiation. And for those that can't get concurrent chemo, which I think would be a very, very few patients, they may get radiation therapy alone. Here, I think Nick was trying to say that there's a lot of confounding when it comes to extent of resection. So the presence of a residual mass, and the extent of resection and the tumor size are all related. And I think I was talking about that in the earlier talk as well. There's a lot of confounding. And once you do those adjusted analyses, like that Canadian registry study that I showed, you don't necessarily need a complete TURBT, meaning an incomplete TURBT still can do equally well. But in terms of TURBTs in the UK and Nick's viewpoint, a residual mass means higher stage. I think we can all agree with that. Higher stage means poorer prognosis. Okay. Therefore, it does not follow that radiation only for patients with no mass post-TURBT, as these patients will also do less well with surgery. And I think we can agree with that there's a lot of confounding with stage and size of tumor, et cetera. Also, it does not follow that a TURBT is actually needed. And I think this is the controversial point that Nick does talk about. Can one just do a biopsy and an MRI versus actual an attempt at a resection, and ideally a maximal resection. And I think there are some differing viewpoints on that. But Nick, Nick feels that perhaps just a biopsy, not a TURBT, may be needed, and has some data to support that as well. In terms of radiosensitization, we went over this earlier, but there's numerous trials showing feasibility and safety, and 3 randomized trials from Canada and 2 from the UK showing that you really should be adding concurrent radiosensitizing agents. They don't necessarily have to be chemo, though. For example, hypoxia-modifying drugs like nicotinamide and Carbagin actually have phase 3 data supporting their use. They're really not used outside of the UK, but certainly has data supporting its use. So here's the NCIC study, older study, 1996, showing adding cisplatin to radiation does better than not. Here's the Beacon study with Carbagin and nicotinamide as radiosensitizers, again showing improved outcomes. And here's the BC 2001 trial with now 10-year follow-up showing improved local regional disease-free survival, local regional control by the addition of concurrent chemo, improved invasive local regional control. Overall survival, not significantly different, but you can see that the curves are separating some. The same applies to bladder cancer specific survival, not statistically significant, but you can see the adjusted hazard ratio there of 0.73. And metastasis-free survival, again, trending towards significance, not quite meeting it. And an improved salvage cystectomy rate, so less salvage cystectomies when using concurrent chemotherapy. So again, as I highlighted earlier, strong data to support that use, and one really should do that. Very few patients are unfit for a form of concurrent radiosensitization. In terms of patterns of recurrence, this again comes from Nick's data. You can see here that in terms of, in this data set from Nick, 50% of patients had any recurrence. The majority of them are local regional recurrences, but a good number are still distant. Out of the local regional recurrences, most are non-muscle invasive and then muscle invasive. They actually have very few pelvic nodal recurrence rates in some of the UK series. I think some other data would suggest a little bit higher rates than this, but certainly pretty low pelvic nodal failure rates. And for that reason, the UK actually doesn't treat pelvic nodes with radiation. They do bladder-only radiation. There is a recent study that came out of Canada, another Canadian registry study, that actually showed perhaps some survival benefit to treating the pelvic lymph nodes in addition to the bladder with radiation. So it's a point of some debate, I think, and whether or not pelvic nodal radiation is necessary. I think as far as data exists today, I think you can do it either way. So looking at non-muscle invasive recurrences, they can be managed conservatively and generally have overall tolerability, toxicity, and outcomes compared to non-irradiated patients when managed intravesically with TURBT and intravesical therapies such as BCG. This is interesting for those muscle invasive recurrences that require a salvage cystectomy. This actually comes from the multi-institutional data that I showed earlier between Toronto, USC, and MGH. And for those that required a salvage cystectomy for a muscle invasive recurrence, they do just as well as those that don't have a muscle invasive recurrence and therefore don't require a salvage cystectomy. So that really tells you for the 10 to 15% of patients that require a salvage cystectomy that it is curative and can be curative and is an important part of the treatment paradigm. In addition, salvage radical cystectomy morbidity is acceptable. Generally speaking, when comparing salvage to primary cystectomies, there's no real difference in intraop and early complications, though there can be some higher late complications such as wound healing complications. Interestingly, in this other MGH series, there was, again, no difference in overall or disease-specific survival in primary cystectomy compared to salvage cystectomy cohorts. So then Nick wanted to turn to kind of patient-reported outcomes and quality of life, and the thought that, does radiation really leave you with a small, poorly functioning bladder? Of course it can in some cases, but I think that ends up being pretty rare. And so what he has here is data from the BC 2001 trial, looking at different quality of life domains, physical well-being, emotional, social, and functional well-being, and really showing you that actually looks pretty good over time compared to baseline. And then in terms of how does survival in BC 2001 compare to SEER data? Well, here's BC 2001 data overlaid on top of SEER data. And so I think he's arguing that it compares pretty favorably, and also in terms of bladder cancer specific survival. So this is his last slide. What is a future pathway? Well, an initial assessment with a flexible cysto, MRI, and biopsy. Okay, tumor profiling with liquid biomarkers. A limited TURBT if needed for staging, but he also questions the need for a TURBT. With no TURBT, MRI could be used for response assessment, tumor localization, image-guided radiation, and adaptive radiation. Monitoring post-initial bladder preservation with cysto, MRI, and liquid biomarkers. And I think we're all talking about those as being elements as part of a definition of a clinical complete response. Surgical salvage is feasible and safe after these newer therapies. And then, as is being discussed today, with new systemic therapies here and on the horizon, it opens opportunities for novel combinations and new approaches to bladder preservation. So with that, I thank you for your attention. I hope I did, Nick.
Thank you, Jason.
Great job, Jason. We're getting there. We're nearly at the end of our formal lecture. So it takes great pleasure to introduce our next set of speakers, who are going to be speaking obviously related to, I think, a topic we're all sort of highlighting related to biomarkers. Obviously, liquid biomarkers are a critical component to our discussion on complete responses. We're going to have two presentations One will be from the illustrious, and he does not require an introduction, Petros Grivas, talking about ctDNA, followed by Liang Chang talking about utDNA. Petros?
Thank you, my friends. Maybe we can put up the slides. I'll start by saying that this is a great discussion. Thanks for getting us all together. I tried hard to put this talk together, and I will start verbally. Hope the slides will appear. And I have to say that we really do not have a lot of data with circulating tumor DNA in the context of clinical complete response. Thank you. And I did actually email Dan Genisman, Andrea Necki, and Matt Galsky, because you guys have done studies in the field, and we're waiting for circulating tumor DNA data in the context of clinical complete response. And I think that's a question that I think, Betsy, you asked in the Zoom earlier. So let me give you some contextual data about circulating tumor DNA. These are my disclosures. And obviously, we all know the different potential application of ctDNA. And today, we're focusing our discussion, in my mind, how circulating tumor DNA in the plasma can add value in terms of defining more stringently and accurately clinical complete response as a biomarker. I think that's the first question we have. And then to the second point, how does this biomarker clinical complete response correlate with long-term outcomes and disease control? So I put this slide together for a talk I gave recently, and I think there's some concepts that are important. When we think about ctDNA as a biomarker, there is obviously a question about prognosis versus predictive value. Is clinically useful, which means if you incorporate it in clinical outcomes, if you incorporate it in the management, does it improve clinical outcomes or not? And of course, there are questions about cost effectiveness, logistical burden of testing, turnaround time, and other logistics, and of course, the tumor-informed, tumor-agnostic assays. These are the studies that we're going on right now. We already heard from Dan and Matt the results from the two studies showing in the bottom of the slide, RETAIN-1 and the Hoosier trial. We still have ongoing studies, RETAIN-2 by the Folk Chase group and the Alliance group by Gob Ayer, which are still ongoing. And again, I would love to see ctDNA data from those studies, again, as we discussed with Dan, Matt, and Andrea earlier. So what data we have today in the context of pathologic complete response, which is different than clinical complete response. And what I will show you in the next few slides is pretty much consistent data showing the prognostic value of circulating tumor DNA in terms of association with recurrence and also pathologic complete response. And what you see in those slides is that there is not perfect, but pretty good correlation with undetectable ctDNA, negative ctDNA in the plasma, and pathologic downstaging. Again, not perfect, but pretty good. And you see that, this is the study by Christensen in Denmark, that if you have clearance of ctDNA, you have higher chance of pathologic downstaging in terms of pathologic complete response, again, at cystectomy, different than clinical complete response, and less chance of recurrence if you have negative ctDNA. Similar studies here. This is neoadjuvant chemotherapy on the top and neoadjuvant immunotherapy in the Abacus trial. Similar concepts. If you have undetectable ctDNA, you have higher chance of pathologic complete response such as radical cystectomy, and you have lower chance of recurrence or death. Again, the message here is ctDNA seems to be strongly prognostic, at least in the context associated with path CR and lower chance of recurrence. Similar data here in that particular slide. As you see on the left, you see ctDNA before neoadjuvant chemotherapy. In the second column on the left, you see ctDNA before radical cystectomy, and then ctDNA during neoadjuvant chemotherapy. And consistent message, if you have undetectable ctDNA or if you clear the ctDNA, you have better outcome. One message I want to show here, though, is you may need more than one time point. You need, as you see, a single time point before radical cystectomy may not tell you the whole story. So you may need to have serial measurements of ctDNA, and that, of course, has to be balanced against the cost and the logistical burden of serial testing, but to have a more complete picture with dynamic measurements over time. This is from the Nabucco trial from our friends in Netherlands. You see, again, similar story. a higher chance of pathologic downstaging if you have undetectable ctDNA, and again, lower chance of recurrence or death in that context. Again, highly prognostic, not perfect, but pretty good. This is the IMvigor010 trial. We published this in Nature a few years ago. This, again, was the prognostic role of undetectable ctDNA was shown, and the hypothesis was generated that negative ctDNA might be predictive of benefit with adjuvant immunotherapy. This is, of course, a hypothesis because an exploratory ad hoc analysis and similar, again, data here. If you have negative ctDNA after cystectomy, that correlates with longer DFS and overall survival. Tombola trial, we saw the data at ESMO a couple of months ago. Very good effort by our friends in Denmark, Lars and others. This trial took patients who had prior neoadjuvant chemotherapy, radical cystectomy, and after cystectomy, they were monitored with serial ctDNA over time. And if they were ctDNA negative, they were monitored. If they became ctDNA positive, then they got atezolizumab. There was no randomization in the ctDNA positive. They got atezolizumab if they became ctDNA positive. And that study, as you see here, tried to evaluate whether if you capture those patients with ctDNA, how do they do over time? And I borrowed this slide from Bogdana, who I know sees on the Zoom call. She did a great discussion at ESMO, and this is what you see from the Tombola trial. About half of the ctDNA positive, half of the patients after cystectomy were ctDNA positive, quite a, I would say, high proportion, and the 3/4 of recurrences detected within 4 months early on. And interestingly, again, ctDNA negative correlated with good outcomes. Only 3% of patients had metastasis ctDNA negative, which was a little bit different than the IMvigor011 study that saw a little bit higher. 10% of ctDNA negative patients had recurrence or metastasis in IMvigor011. Overall, though, same message. It's highly prognostic, not perfect, but very good. And about half of the patients met the primary endpoint of no evidence of disease if they're ctDNA negative. Overall, I want to raise those questions which are relevant to our discussion. A prognostic role doesn't always mean predictive role. Serial ctDNA may be needed to have more information over time, and that again can generate some logistical burden, cost, and time. We may need additional biomarkers, and the question I think is how the ctDNA correlates with clinical complete response as a biomarker. How does it contribute to its robustness as a biomarker? And I want also to point out we have the ongoing trials IMvigor011 and the modern trial. Tom Pauls and Margalski are leading those. I think that will be important trials to evaluate clinical utility of ctDNA in the adjuvant setting. And the last point I will make is we still need to, as I mentioned before, to have more data with ctDNA in the ongoing trials looking at clinical complete response to evaluate this association and how much it contributes to the stringent definition of CCR and evaluation with a correlation with long-term outcomes. Thank you.
Nice job, Petros. Just for time purposes, we're going to go straight to Liang's talk. Liang, are you able to join us and put up your slides? Can you hear us?
Yeah. Can you see the slides?
Yep. Perfect.
Okay, great. Thanks everyone. Good morning or good afternoon. And I think pictures really get a good layout. The framework. I think this is I hope we're all convinced. That's ctDNA liquid biopsy is probably the next generation biomarker that's going to be critical role in terms of all the clinical trials and disease biomarker. And so I'm going to, for sake of time, I'm just going to be a very brief presentation and go through. I try to convince you that UTDNA is probably it's not going to be. It's going to be complementary. It's not going to replace ctDNA, but it's going to be very complementary to the UTDNA, ctDNA. All right, so let me see if I can advance to next slides. And so liquid biopsy, and I think it's probably it's become indeed has become a standard of care and part of the clinical trials in many other cancers. And and more so and in the GU cancers, and especially in the bladder cancer. And it's well known. And I think this study was really this, this early study published in 2019 from last group. And this really is one of the landmark study and the first time in the large scale, and showing that the ctDNA is a prognostic biomarker here, and showing that this is it's highly significant. The presence of ctDNA predict patient outcome. And this paper was published in 2019 and in the Journal of Clinical Oncology. And this is another study that everyone know about. This is our study that Peaches also mentioned that. So the ctDNA is highly predictive of patient outcome in the adjuvant immunotherapy setting. So what I'm going to talk about here today is next couple of minutes is really this UTDNA, urine tumor DNA. And one caveat, one thing we have to keep when we talk about UTDNA, there's two types of tumor samples. One is the supernatant, one is cell palette. So I think a lot of data we talk about, still very limited data, but I think it's important when we say we want to do UTDNA, and so when you talk about supernatant or cell palette, so there's some there's some difference. And so here's the study just published this last year from same group, and I think they have extended their cohort, and now they including the three. So this is the first time I've seen. I think this is the first time I've seen the data upon head-to-head comparison between urine palette and urine supernatant, and also showing here's a combined UT circulating liquid biopsy from blood plasma DNA and the urotumor DNA. What we can see here, the take-home message here is that it seems that urine supernatant perform better, and at least in this cohort, is significant in predicting recurrence-free survival in the patient who receive adjuvant chemotherapy. In the contrast, the urine palette, is not predictive. And more interestingly, I think it's the data showing that if you combine using both the plasma DNA and the supernatant urine supernatant DNA, urine tumor DNA, they are highly predictive of patient's response. I think this is very important message that so probably in the future clinical design, and we should using urine supernatant, which is, it actually makes things much simpler, easier. Then you don't have to process the spin the urine. So it's really, I think it's additional supporting data showing that. And and this is another study, that was published, this last year again in the clinical cancer research, and the data is really stunning. I think there's even they have very limited patient, and here this using the urine tumor DNA, and also showing that there's a tumor fraction based on the somatic mutation, they can achieve the AUC curves 0.969. That's truly stunning. I think if this can be duplicated, the results, I think it will be become the standard of care in terms of a disease biomarker. And this is another study, and I think it's from the last group as well, showing that this is the BCG treatment setting, showing that this is a study published early this year in the European Urology. And here in this study, the extended cohort, they have 236 patients, and they analyze 234 urine samples, 751 biopsies, again showing that the presence, just like plasma DNA, and this is highly predictive of patient treatment and clinical outcome, and so the p-value is 0.029. And more interestingly, and also the investigator proposed so-called the field cancelization concept. In essence, it's tumor mutation burden. And so if you're more mutation, the patient will tend to do worse. So this is kind of interesting study. But again, we can see the emerging evidence that urine tumor DNA can be served with a very strong progress marker. This is my last slide, and so I think just the UTDNA we talk we just hear more. I think we don't have time to talk about it. This could be used as a for diagnosis, assist diagnosis, and also for early cancer detection, and can be used for the monitoring tumor recurrence, and also you could also predict biomarker like FGFR3, mutations from UTDNA, and that's important prognostic biomarker as well. And so I think this is going to be future clinical trial design. I think I would think that we should consider, in addition to have a liquid biopsy plasma DNA, but also we should consider UTDNA because it's such easily accessible samples. And so, okay, I will stop here.
Okay, and in the interest of time, we'll move on to the final talk in this session, and it's statistical considerations for the design of randomized trial incorporating a response-based approach. Drs. Alexia Lasanos and Dr. Irina Ostrovania, if you're online, looks like you are. Great. Thank you so much for hanging in there, and looking forward to hearing what you have to say.
I'm trying to share the screen, but it doesn't let me.
We did see your screen briefly.
You did. Okay.
Yes, we see it.
Okay, perfect. Can you hear me okay and see the screen?
Yes.
Great. So I'm Irina Ostrovnaya. I'm a biostatistician working at Memorial Sloan Kettering Cancer Center with a bladder oncology group. And I also work with Alexia Yasunas, another fellow statistician, for this presentation. I appreciate you including a statistician in this discussion. So as it's been said a lot today, standard of care for muscle-invasive bladder cancer often is neoadjuvant plus cystectomy, but a lot of patients on cystectomy will have no cancer. So removing a bladder might have been unnecessary over treatment, and it's a life-altering surgery that a lot of patients will try to avoid. So the major question we're trying to assess with the next kind of clinical trial for bladder sparing is, can some patients avoid cystectomy and without much decrease in cancer prognosis, and which patients should be selected? So these are the major questions we're trying to assess. So if I'm thinking about the ideal design that would address these questions, we would want a long endpoint, something like a relapse-free or cancer-specific survival, so that would capture the death from cancer, that extra death from cancers that would happen if we didn't remove the bladder. And since not removing the bladder this is the intervention, is a kind of a less treatment, a non-inferiority trial seems to be appropriate. How much the extra risk we're exposing the patients to, and if this extra risk is not too high. And finally, who would benefit from bladder sparing? Of course, you want to pick patients who have the highest chance of having a path CR, so no cancer and cystectomy. And the way to do it is either CCR, which has been discussed today, or some biomarkers. But potentially, there could be, if bladder sparing and cystectomy would have, in some populations, about similar outcome, you might want to consider more wider population. I'm reviewing here three trials, two of which were already presented actually at this meeting, just from statistical viewpoint. So one trial that has not been presented in detail is GOPA-IR's Alliance trial, where patients were giving dose-dense or standard GemCis as neoadjuvant. And if they had less than CT1 response and deleterious DDN alterations, they were offered bladder sparing. So the primary endpoint for this trial is 3-year event-free survival among bladder sparing population, and it's powered for testing the null hypothesis that this event-free survival at 3 years is 80%, which is undesirable, while 90% will be desirable, with 80% power and 10% one-sided type 1 error. So it's a single-stage binomial design with this binary endpoint among bladder sparing patients. So the question this design would answer is not necessarily, is this how much worse the bladder sparing in this particular patient population than a cystectomy. Instead, is it what's kind of the 3-year EFS is in this particular population of less than CT1 and the DDR alteration. So another trial that was presented today, so I'm not going to talk too much about it, but presented by Matt Galsky, but this trial is powered for to test whether the positive predictive value of CCR to predict the 2-year MFS exceeds the confidence interval for this positive predictive value exceeds 80%. So again, patients are not directly compared to patients treated with cystectomy. So this trial more evaluates CCR as how accurate is it a biomarker on predicting the outcome on surveillance. And another trial, again presented today with great information, is a RETAIN trial that treated patients with bladder sparing if they had a CT0 and one of the 4 mutations. And the primary endpoint is MFS, metastasis-free survival at 2 years. And it's assessed at both bladder sparing and bladder sparing and patients who did not undertake it, so in general population. Just a few points from these designs. So they have slightly different definition of CT0. 2 out of 3 have a biomarker eligibility for bladder sparing, and they test different hypotheses, but because they're single-arm trials, they are not directly comparing bladder sparing to cystectomy. Okay, so if we think about how to choose patients for these trials, I have this hypothetical table here of proportion of patients who are cancer-free, or in more realistic terms might be path CR patients. So if we had a great definition of CCR that will be highly predictive, and we have a good biomarker, which will predict who will respond well to neoadjuvant therapy, maybe the combination of CCR and marker-positive patients would have 100% free patients who are 100% cancer-free. And if we choose this population for our next clinical trial, that's the population that will have least risk from bladder sparing, which is great. But on the other hand, we will not learn how much risk the other patients would be exposed to. And it will be arguably unethical to randomize these patients to having cystectomy if we're very confident that they're bladder free. On the other hand, as was mentioned, the clinical complete response is not an established entity. And for the purposes of evaluating bladder sparing, I do see CCR as a biomarker as opposed to an endpoint, because that helps us choose patients, but not necessarily, it doesn't evaluate the effect of bladder sparing versus cystectomy. So, and biomarkers could be different for different therapies. And as you know, landscape is changing. We have immunotherapy and potentially other therapies for whom we can have for which we can have different biomarkers. They could be prognostic or predictive. So it's possible that the effect of biomarker is not there if you condition on having a CCR, which also was brought up today, but it could be therapy and biomarker specific. So there's a lot of uncertainty about what should be the best genomic biomarker and what. So I'm trying to argue that if you loosen the eligibility for patients to not restrict them to biomarker positive patients, it's a higher kind of better rationale for randomizing patients to either to cystectomy or bladder sparing, because there's more uncertainty how well they will be doing. So okay, so just then some ideas for the randomized trial that I think would yield the most information is it would be in an inferiority trial. And I know it's a big deal whether it's ethical to randomize patients who are doing well to surgery, but again, it's a standard of care, and there's not enough uncertainty to know how well patients would do with or without surgery. So there are precedents in prostate surveillance trials where patients were randomized to active surveillance or surgery or radiation. So there's definitely precedents for such trials in similar situation. So questions that would be considered whether patients should be randomized to cystectomy versus active surveillance, or perhaps cystectomy, active surveillance, and some adjuvant therapy. And I argue that not restricting to biomarker positive population will allow you to learn more about the effects of these biomarkers on risk, cancer risk with either treatment. So there could be some stopping rules for biomarker negative patients to control kind of the risk for patients who you feel like are not going to benefit as much with bladder sparing. So since it's I argue that non-inferiority trial is really the best question here. Is the bladder sparing, how much risk it is exposing the patients to? So, but non-inferiority trials are often large. So, but having large margin for non-inferiority might make it more feasible. And finally, if you again expand the availability for eligibility for these patients, but to mitigate the risk, extra risk, you would maybe introduce some cfDNA monitoring or some other monitoring of early recurrence. So I just want to argue that randomized trial is what would give you the most information to present the most to present to your patients so that they can choose, make an informed choice whether they willing to choose a bladder sparing and what kind of risk is associated with that. So finally, if a randomized trial is not feasible, I would argue single arm trials could answer some of these questions. But it's important to consider clinically meaningful question. I apologize. So with a single arm trial, but it's important to have a meaningful clinical control. For example, if it's a trial of patients who have CCR and a certain biomarker, the historical control would be how would this particular population of patients do on with cystectomy, so that you can that's what the bladder sparing outcome should be compared to. So specific to this particular subgroup that is chosen for single arm. But again, I think while randomized trials might be large and will potentially require collaboration across different centers, and but they would give the most information that for the patients to have informed decisions of risk versus benefit of bladder sparing.
So thank you, Rina. I think that we should wrap up this consensus meeting. Well, I think that we have discussed quite a lot of topics, issues, important step forwards. So very enthusiastic about the discussion today. I cannot be more thankful to all of you for what we have generated today. I think that we fundamentally agree on the main pillars, of what could be a next step for the definition, or shared definition or use of clinical CR, or right endpoints to use for the next trial design. So what we are thinking is to run a poll after this meeting to all of you, to ask you voting on the very, very focused topics that we have discussed today, and trying to see if we have reached kind of a consensus according to the IBCG methodology. So there will be a follow-up short after this meeting. Again, you will have access, and then the team will work on granting you access to all the material of the meeting, abstracts, slides. So thank to all of you who have provided a lot of material, fantastic material, guys, that is implementing the available literature. So if there is no additional words, I have to close the door here, and thank to all of you for being here, and let's touch base soon by email for the next steps. Thank you very much again. And thanks to the organizing agency, fantastic work as yesterday as usual. Thank you.
Recording stopped.